we can wait 48 hours, and then you can go for this limb again. And if patient is started on enteral feeding, and if they are not tolerating, so you are coming into this part of the algorithm. And then like patients having high gastric residual volumes, vomiting, diarrhea, and other conditions where you cannot go for enteral feeding, then we have to go for parenteral nutrition. And if patient is having at the beginning any absolute contraindication, then we have to go for parenteral nutrition. Likewise, you can use this kind of an algorithm to treat the patient or to give patient nutrition. So in enteral feeding, if patient cannot take orally, you are familiar with this tube, nasogastric tube is inserted. How we are going to insert it? Yes, you have to get the length from the nostril to the tragus and from the tragus to the siphisternum, and then you have to get the estimated length where you insert, and then you have to insert it. If patient is conscious, you have to apply some local anesthetic gel and insert it, and then you have to confirm the position of the NG tube before you start the enteral feeding. So how to confirm the position? Yes, by the chest X-ray is the gold standard, and you have to see the tip of the tube within the stomach. And what are the other methods we use? Yes, you can aspirate for the stomach contents, and also a commonly used method would be whoosh test. That is, you take about 20 cc syringe and inject through the NG tube about 10 to 20 cc of air and auscultate over the stomach for the sound of the air passing into the stomach. So it's called the whoosh test. And even though this is not the gold standard, this is a commonly practiced method to confirm the NG tube position. As well as the other method would be to use a pH strip to confirm the acidity of the stomach content. What are the safety measures you should follow during the NG tube feeding, NG feeding? So yeah, first thing is to confirm the position, then keeping the head up position about 30 to 40 degrees will be also preventing the aspiration of gastric contents, especially a patient who is unconscious. And also intubated or patient with tracheostomy tube, you have to check the cuff inflation, which will prevent the aspiration of gastric content to the lungs. And also you have to aspirate every 6 hours and see whether patient is having feed intolerance. And also usually we replace this aspirate back into the NG tube to avoid any electrolyte losses. And usually continuous drip feeding is what we recommended, but even it is continuous, we have to stop every 6 hours with a break. When you move to parenteral nutrition, the important thing is you should have a venous access. Now earlier, we didn't have preparations which can be given peripherally. And so we had to always go for central venous access. And nowadays we have a preparation which can be given via peripheral cannula. And if it's a parenteral nutrition administration through the central line, it has to be a dedicated central venous access. And the problem would be this central venous access line can be a source of infection. So we have to keep these lines very clean, covered, and dedicated only for nutrition. And also, before you administer these nutrition preparation, we have to check the expiry date, discoloration, and change in consistency. And during the handling of these preparations, we have to maintain hand hygiene, sterility, which can prevent the line-related infections. So in these days, we are talking about the corona COVID-19 patients. So we have to start nutrition as early as possible. Most of the patient you can give oral feeding, NG feeding, but and if patients are intubated, you have to go for NG feeding or indicated for parenteral nutrition. Next, we are going to talk about DVT. So DVT is deep vein thrombosis, and it is incidence is about 0.5 to 1 per thousand population. And what happens is there will be clot formation in the deep vessels in the uh, lower limbs, especially patients who are having trauma and patients with intravascular catheters, because then there will be interruption in the blood flow in these deep vessels, veins, and so there will be stagnation of blood and formation of blood clot. So what is the bad effect of this blood clot formation? Yes, these blood clots can break off and can travel to the right side of the heart and then to the lungs, resulting pulmonary embolism, and could be even severe pulmonary embolism, resulting cardiovascular instability and even the death or the cardiac arrest. So important thing is prevention of DVT. So even at the time of admission to the hospital, until the discharge from the hospital, we have to treat this patient, or we have to administer DVT prophylaxis. So who are the risk category patients? Patient with indwelling venous devices, patient who had surgery, especially abdominal, pelvic, orthopedic, major trauma, malignancy, pregnancy patients, and also patient with history of DVT, and also patients who are obese. And what are the strategies to prevent? Early mobilization, physiotherapy, and adequate hydration, which will uh, keep the blood viscosity normal. And also we have mechanical and pharmacological methods. So what are the pharmacological agents we have? So commonly administered agent would be low molecular weight heparin. Now we have two types of heparin, that is unfractionated heparin, and the other type would be low molecular weight heparin. So the low molecular weight heparin would be preferred over unfractionated heparin because you have to give as a single daily dose, and you don't need to monitor the treatment, because if you are giving heparin, you have to monitor with APG. And also heparin is associated with uh, heparin induced thrombocytopenia, which you don't see with low molecular weight heparin. So the advantage of heparin would be in patient with renal failure, heparin would be preferred over low molecular weight heparin. In our setup, the commonly administered drug is enoxaparin, and in DVT prophylaxis, we usually use 40 milligrams subcutaneous once daily. So in body weight, it would be like 0.5 milligram per kg. And sometime we might use in dalteparin as well. If it is heparin, that dose would be 5,000 units subcutaneous, either twice daily or thrice daily. And in DVT treatment also, we are using same drug and with a higher dose. So other options which we are not currently much available would be fondaparinux as well as rivaroxaban, which are directly acting on factor 10A, but these are not available widely. And what are the contraindications before you starting these drug pharmacological treatment? So there are absolute as well as relative contraindication. And the absolute contraindication, if patient is already on anticoagulant like warfarin, we are not starting these anticoagulants. And also, if patient is having major bleeding, which is active, and recent clinically significant bleeding, thrombocytopenia of platelet less than 50,000, the absolute contraindication, and inherited or acquired bleeding disorders like hemophilia. And relative contraindication is you have to weigh the risk and benefits of starting pharmacological treatment, and it is a case by case you are assessing the risk and benefit of starting treatment. So such as patient who had surgical procedures, patient with recent GI or genitourinary bleeding, recent central venous system bleeding, and also uncontrolled hypertension, and also patient with any condition is associated with high risk of clinical bleeding. It's always assessed by case by the treating clinician. So what are the mechanical methods? We have two methods. The first method is graded compression stockings. So this is widely available, and here you use this stockings, which is applied over lower limb, and it is designed in a way where it is exerting a pressure over the limbs and which is graduated. So where you get a higher pressure over the ankle than the calf, where the blood, the venous blood will be pumped towards the calf, and then again you have a bit higher pressure over the popliteal region, and then lower thigh you have a bit higher pressure, and then a reduced pressure over the upper thigh. So this is there are pressure gradient where it will augment the blood flow towards the heart. So this stocking has to be selected according to patient's height and the size of the limb. So always you have to measure the size and then give the proper size for the patient. Otherwise, if it is too tight, it will cause damage. If it is too loose, there won't be the expected result. And the other methods which are not widely available is intermittent pneumatic compression pump, which are more effective than the graduated compression stockings. And what we use here is we have bladders or the cuffs which are applied over the lower limbs, including the thigh and the calf. And then this is connected to a pump, where this pump will be intermittently inflating and deflating these cuffs or the bladders, which will act as a mechanical pump to pump the blood from the lower limbs to the heart, which where you have to use it in patients who are at very high risk of developing DVT, because these are not widely available. And the problem would be these cuffs or the bladders would be disposable. Then the availability is the problem for our patient. What are the contraindications for mechanical DVT prophylaxis? Yes, so you have to think whether patient is having any these conditions like severe peripheral arterial disease or ulcers, recent skin graft, peripheral arterial bypass grafting, severe leg edema, and also any patients having allergy to these material, and any local problems on the legs like gangrene, dermatitis, and fragile or tissue paper skin. And when we think about COVID-19 patients, we administer DVT prophylaxis as soon as possible because they are known to have microvascular thrombosis systemically. So all the patients are given DVT prophylaxis unless there is absolute contraindication. Bit of physiotherapy, yes. Physiotherapy, very important in all the ICU patients because these are immobile, intubated, somehow intubated and on ventilator, and they can result adverse respiratory and musculoskeletal complications. So objective in physiotherapy in the intensive care is to prevent respiratory complications. What are the complications? These patients immobile, even intubated, they are having problem with clearing secretion. They don't have normal breathing, normal cough won't be there. So what happens is secretion will be stagnated in the lungs and it will result atelectasis, that is collapsing of the alveoli, and then it will act as a focus of infection, and then also the oxygenation will be impaired because of the atelectasis. So we have to give physiotherapy to prevent the atelectasis as well as recruiting, that is to open up the collapsed alveoli and to improve ventilation. And also when you give physiotherapy, it will help the patient to wean from the ventilation. And also musculoskeletal physiotherapy will prevent the intensive care acquired weaknesses, neuropathy, myopathy, and also it will prevent deep vein thrombosis. So we have certain procedures used by the physiotherapists, like in intubated patient, we use manual hyperinflation, ventilator hyperinflation, positioning, percussion, vibration. You might see in the intensive care unit how the physiotherapists do these methods. And in non-intubated patient, we can mobilize the patient as early as possible, and also application of non-invasive ventilation, continuous positive airway pressure, and also encouraging the patient to have deep breathing exercises, incentive spirometry, all will act as physiotherapy modalities and will improve the patient's breathing. So in patient with COVID-19, we need to give regular physiotherapy, but in patients who are intubated, And also, even not intubated, when giving physiotherapy, the risk is the aerosol generation, which is a risk factor or risk to the healthcare staff member. So, all the patients will be approached with PPE, and also in intubated patient, we always recommend closed suction, where we have separate suction unit attached to the endotracheal tube, where you don't need to disconnect for suctioning. Is called closed suction unit, which will prevent the aerosolization of the environment. So you don't need to disconnect, and you can aspirate the secretion directly with through the suction apparatus without disconnecting the tube. And also, extreme caution has to be executed to avoid unintentional disconnection of the ventilator circuit. Fourth aspect is prevention of bed sore. What is a bed sore? It is a localized injury to skin or underlying tissue, usually over a bony prominence, as a result of pressure or pressure in combination with shear forces. So what happens here is there will be compression of the soft tissues over the bony prominence. And what happens is there will be interruption of local blood supply, and then the oxygen nutrients to the capillary, and the capillaries or the tissues will suffer tissue ischemia. And also blood supply interruption cause interruption of the venous return and leading to edema. So what happens is ultimately there will be ischemia and tissue death. So what are the vulnerable locations? It's over the bony prominences like sacrum, coccyx, heel, and also over ear. You can see in these images where patient having various degrees of bed sores or the pressure ulcers. It's not uncommon in ward setup, but in the intensive care units where we have very good nursing care, we usually don't see development of bed sore, and it is an indicator of the quality of the nursing care in an intensive care unit. So what are the implications of bed sores? Yeah, definitely it will prolong the hospital stay, and the cost will be increased, and in the patient staying for a long time, the mortality will be increased, and also, as I have mentioned, it is indicating the quality of nursing care. So how to prevent bed sores? Risk assessment, skin assessment, surface support, turning, nutrition, repositioning, wean vasopressors as early as possible, and we have to optimize the nutrition in targeting hemoglobin and the albumin level. So risk assessment, there are various tools used by the various institutions and the countries like Norton scale, Waterloo scale, modified Braden scale. I'm not going to detail, but I will be showing this Waterloo scale for you to have an idea what are the risk factors to develop bed sores. So if you see on this right left upper corner, you have the BMI. So more the higher the BMI, the patient is at risk of developing bed sores. So high BMI as well as low BMI. Then patient's skin type and the age of the patient and the sex of the patient. So female are at risk of developing pressure sores, and also malnutrition. Then you have continence with the patient having urinary or fecal incontinence, and how mobile is the patient. And also there are special risk factors like terminal cachexia, multiple organ failure, peripheral vascular disease, anemia, smoking, and any neurological deficit. All are risk factors, and after adding these risk factors and other scores, you can get a score of could be 10 or 15 or 20, and you will assess the patient as whether at risk or at very or high risk. So these tools will be useful to assess the risk and prevent bed sores. So how to assess the skin? Yes, we have 4 grades of bed sores. In grade 1, we have erythema of the intact skin, and there will be discoloration with skin warmth, edema, induration, and hardness, and but still skin is not damaged. But when it comes to grade 2, there is skin loss, partial thickness skin loss involving epidermis and dermis. You can see it from here. And usually this ulcer is superficial and present as an abrasion or a blister. And when we come into grade 3, there will be full thickness skin loss involving damage or necrosis of the subcutaneous tissue, and even extend down to the underlying fascia, but not to the fascia. When it comes to grade 4, there will be extensive destruction, tissue necrosis, damage to muscle, bone, or supporting structures with or without full thickness skin loss. So what are the surface support methods we have? Yes, we have to avoid hard surfaces, wires or bed railings, which is with directly contacting the patient, especially for prolonged period, and also avoid skin creases in linen, and also air water mattresses will prevent bed sores in high risk patient, and also we have to prevent skin soiling with stool as well as with urine. So catheterization and using diapers will prevent the skin soiling. And also we have to turn the patient side to side to supine every 2 hours. Where will offload the skin, and especially where the integrity is compromised. And also after developing of the bed sore, we have to go for wound cleaning, debridement, and so good care is important to heal the wound. So in COVID-19 patient also we have to use, especially if patients are not mobilizing, and bedridden and intubated patient, we have to think of preventing bed sores. So the last area I'm going to talk about is about peptic ulcer prevention. So in critically ill patients, they are at risk again because of stress-related ulcers. And most of these ulcers are superficial and asymptomatic. But certain patients, they can result large erosion of large vessels and life-threatening GI bleeding. So it is among ICU population about 0.6 to 6% of incidence. So you can see some erosions and also a peptic ulcer. So why they are at risk? Because they have decreased mucosal blood flow, and also then mucosal integrity will be lost, and then erosions of the submucous and muscle layer, bleeding from erosion and erode blood. Then you can get the blood vessel erosion. So what are the risk factors? Prolonged mechanical ventilation, sepsis, major surgery, severe burns, and myocardial infarction, high dose corticosteroids, trauma, hypotension. There are many risk factors in patients who are in the intensive care unit. So what we are going to do is we have to we are giving routinely peptic ulcer prophylaxis. So we are starting with H2 receptor blockers such as trentidine, famotidine, and also we at sometime patient at risk proton pump inhibitors like omeprazole, pantoprazole, and other drugs which are available would be sucralfate as well as antacid. And also, I have mentioned earlier, enteral feeding is protective against peptic ulcer formation. So all the patients with COVID-19 are administered with peptic ulcer prophylaxis. So that comes to end of this lecture, right? I think we can move to the next lecture. I don't know whether we have.
There are a few questions, so we can take 5 minutes and.
Yes, sure. Yeah, I think we have few questions. One asks, well, can repeat the metoclopramide dose? Yes, it is 10 milligram 3 times a day. You can give IV or oral. Okay. And so can you please again, which why heparin is better than low molecular weight heparin in renal failure? Yes. Because now low molecular weight heparin is excreted unchanged via the renal system, and then what happens is if there's renal failure, low molecular weight heparin would be accumulated and result in a higher dosage in the higher levels in the plasma, which can cause a higher concentration and result adverse effect. But heparin is metabolized and in the liver. That's why heparin effects won't be a big problem in renal failure. So that's why we use heparins rather than low molecular weight heparin in renal failure. Yeah, if patient is having deep vein thrombosis, yes, you have to go for the uh, treatment dose of either heparin or enoxaparin. And usually we go for about roughly 7 to 10 days, and then you have to go for other like IVC filters, and then sometime patient is put on lifelong warfarin or any other anticoagulant treatment. Yeah, so you have to get the, I think I have shown in that picture the measurement you have to get for the prescribing stockings. So you have to get the diameter of the thigh, as well as the diameter of the calf, as well as the length from the uh, mid thigh to the foot. So those are the measurement, and usually uh, you have to get it down from outside. It's not available in private hospital setup. So there are usually prescription charts which you can use, and in there you can measure the patient's measurements and write down on that chart, and then can be given to the patient's relative, and according to that you have to get it down. Uh, yeah, pressures of management medications, we don't have, like it's like normal wound management, right? There might be some local applications, but if it is infected, yes, we have to apply antibiotic. But regular dressing of the wound is the one that we do in the intensive guidance, and with the surgical opinion is the management for the bed sores.
Yeah, there's one more question saying
Yes.
how to write referrals on prescription on BST. That lecture will be done by College of Administrators. That is that a part of the whole training session. So that part will be discussed in due
Okay.
that session. So thank you very much, sir. Next
Okay.
is
Thank
Dr.
you.
Gayatri Sharmila, consultant anesthetist at DGS Nuerelia on acute kidney injuries. Right, over to you, madam.
Okay, thank you. Can you hear and see my presentation?
Can hear you. Presentations not yet.
Okay. Um,
Might have to close and restart, I suppose.
uh, is it
I'm sorry. Dr. Gayatri, are you there? I think there's small connection problem. She's connecting from Norelia. I think there's a reception issue, so we'll give. She'll join in shortly. So So Dr. Gayatri will join shortly. So until she joins, from September 1st to September 3rd, we will have pediatrics training. So we will send the emails to you, the timetables to your email and the link. And on 6th, we are having internal medicine. And 7, 8, we have emergency medicine. And on 9th, psychiatry. And on 20th or 19th, they are not confirmed. We'll have College of Surgeons session. Then 23rd, I think we might have College of Medical Administrator training and another session from IDH. That's the plan and the closing ceremony. So for major specialties like critical care, pediatrics, emergency medicine, we might have a practical session. So booklet will be sent to your emails. So what you all have to do is go to the nearest base hospital where the consult is available and get that skills. Get those skills, and there's a booklet you get signature from the relevant consultant. And at the meantime, we will have a common MCQ for the whole session, including today's and the respective session, respective specialties. So those who have successfully complete those MCQs will get a certificate. So Dr. Gayatri is here. We'll start the session now. You're good to go, Doctor.
Okay, sorry about that.
That's all right.
My presentation is on acute kidney injury. Still, I think you can't see my presentation, is it? Can you see my?
You have to make it full screen. That's all.
Yeah. Yeah, I think now you can see.
Yes.
Yes, sorry about it. So my topic is acute kidney injury, and it is very important. And so we'll go through the objectives. First, we'll see why we should need to learn about AKI. It is simple, but it can cause catastrophic events. So it is very important. Then definitions, there are various definitions. And then risk factors and causes. There are always overlap between risk factors and causes. And we'll discuss how we are going to identify AKI and classify the severity. Lastly, I'm going to discuss about the management. Firstly, we'll see why it is important, because it increases hospital mortality and morbidity. So because of that, there will be a lot of complications happen. And then at the same time, ICU admissions, it is about half of the ICU admission in general is due to AKI. Because of all these things, obviously hospital cost increases, and it will be a burden to the government. So it is very important to manage acute kidney injury. Definitions, there are various definitions. Firstly, I am going to discuss about a simple definition about acute kidney injury. So first, you have to know what are the functions of kidney. Usually, renal excretory function and homeostatic functions are the main two functions. So there will be a rapid decline of those functions. So what will happen? there will be an accumulation of the waste products, especially nitrogenous metabolites. And at the same time, there will be a fluid imbalances, fluid overload, obviously, and electrolyte disturbances and acid-base disturbances. So in general, this is what AKI. But so there's another definition. This is produced by KDIGO. KDIGO is an international body which produce guideline related to renal diseases, and they regularly update their guideline. So according to that, AKI defined with the serum creatinine or urine output. So if you have a 48 hours apart value, and now it has increased by 0.3 milligram per deciliter, then you can label the patient as AKI. And sometimes you can have a baseline value of the patient, so at least 7 days prior value, and now it has increased by 1.5 times. So then again, you can say patient is having a renal impairment. Having said that, I think you are aware that creatinine start to rise at the latter part of kidney damage. So I prefer to go by urine volume. As you all know, so usual urine output, it is 0.5 ml per kg per hour. But it can reduce, it can reduce, and if it is reduced continuously for 6 hours, so then you can, it is alarming. So you can see it is, you can detect it within hours rather than waiting creatinine value and the previous value. But if it is available, you can get that value and diagnose as acute kidney injury. So that is the definition. And then we'll go through the risk factors. There are a lot of risk factors, but I just highlight important and common risk factors. You can see like some of them you can't modify, right? Gender and age, especially with age, the kidney residual volume is anyway reduced. I mean, the renal tissue is anyway reduced, and there will be so they are more vulnerable to get acute kidney injury. Comorbidities. So hypertension and diabetes, you know, those are very common. And if especially they are uncontrolled and for going over years, so then they can have nephropathy. So it is another risk factor. Talking about malignancy, it is now kind of very common. So sometimes malignancy itself can cause kidney damage. Sometimes there are chemotherapy and surgical interventions. Various things related to malignancy can become a risk factor for AKI. Then infections. So we are in a COVID era. So again, COVID also complicating the patient with AKI. So it is important in when we consider current situation of the world. The other infections, UTI or any other infection which can lead to systemic complications, septic shock, they can cause renal impairment. Then surgeries, especially emergency surgeries. Emergency surgeries means patient needs surgery maybe within a few hours or within 24 hours maybe. So those patients are critically ill, and so they are vulnerable. Major surgeries, that means like intra-abdominal major surgery or intrathoracic or any other complicated surgery. So there will be fluid shifts, a lot of drugs are given, and various things can happen. So, so they are vulnerable. And blood transfusion. So it is not just HB is low and you are just giving blood. So there are a lot of side effects of blood transfusion. So one thing is it can damage the kidney. So you have to be careful. Medications, there are a lot of medication which cause renal impairment, but common things like non-steroid anti-inflammatory drugs, some of the antibiotic, and don't forget contrast. It is a separate topic if we discuss, like contrast-induced nephropathy. So try to avoid unnecessary contrast, using investigation with contrast. So these are some of the risk factors, and then we'll discuss about the causes. Always better to have some kind of classification. So it is classified pre-renal, renal, and post-renal causes. And just focus on this, the figure, not the content. So I just want to highlight that pre-renal means it is the before the kidney. That means the blood supply to the kidney can get affected and lead to renal impairment. Then the renal, that means the renal parenchyma, which contain like nephrons, glomeruli, interstitium, and blood vessels. So if any pathology related to that renal parenchyma obviously lead to renal impairment. Then the rest of the urinary tract, if there's a pathology, especially if there's an obstruction, obviously with calculi or tumors, or maybe external pressure from the other abdominal and pelvic organs due to various pathology can lead to renal impairment. It is called post-renal. Let's discuss in more detail causes. Why it is important, like when you are managing, you have to identify the cause and treat the cause. So it is a common statement to all the medical conditions. So it is applied to the acute kidney injury also. So that is why I want to highlight, you have to identify the cause and treat the cause. So you have to know the cause. There will be one cause or various causes. So we'll see pre-renal cause. So you can, it also you can classify like hypovolemia. So how hypovolemia can occur. Maybe patient is bleeding, maybe trauma, postpartum hemorrhage, etc. Then dehydration, severe diarrhea, vomiting, or any fluid loss. Extravasation of the fluids with the inflammatory conditions, and then hypotension by any reason, and hypovolemia is common with sepsis. So you will learn about sepsis in next lecture. And then, so those are the causes for hypovolemia. Then cardiac issue, like low cardiac output status, obviously with heart failure or any other complicated cardiac conditions. Maybe fixed cardiac output status like aortic stenosis. So those things can cause renal impairment. There's a thing called like the kidney heart crosstalk. So if the heart get affected, there's a direct effect to the kidney. So those are the pre-renal causes. There's another pre-renal group of causes. So that is the local impairment of renal circulation. That is mainly happen with medications like non-steroid anti-inflammatory drugs and other medication. And renal artery stenosis, that is a common renovascular disease. Then if the patient is having chronic kidney disease, on top of that, patient can get acute kidney injury. Liver injury, liver impairment, so you must have hepatorenal syndrome. And abdominal compartment syndrome, that means increase in intra-abdominal pressure, the pressure affect the renal circulation. So those are the pre-renal causes. Then renal causes, as I said, so tubules can get affected with infection, inflammation, drugs, and the metabolic syndromes. Common thing is diabetes mellitus, and then autoimmune conditions. You must have heard glomerulonephritis, vasculitis. So if you identify the cause, you have to treat the cause, right? Then post-renal, I said it is obstruction mainly. So the common things may be urinary tract related, prostatic hypertrophy, calculi in various parts of the urinary tract, and bladder tumors, and external pressure from pelvic masses, and retroperitoneal fibrosis, which can affect the urinary tract. So those are the causes. I think you can see like there are sometimes overlap between risk factors and causes, but you have to find out the cause when a patient is having renal impairment. So this is the severity assessment. I'm not going to go in detail. This is called rifle classification. So there you classify the renal impairment. So that means assess the severity. So it is based on GFR or serum creatinine and urine output. I just want to highlight, if the patient is in the ward at risk stage, you have to detect the patient at that time. No need of, no point of detecting at failure stage. That means there's a kind of medical negligence, I can say. So you have to identify it at the early stage. Otherwise, so the damage is more, so it is more difficult to correct it. So management will be more complicated. That is what I want to highlight, right? So this is also available in KDIGO guidelines. And so now you know what is AKI causes and how you are going to assess the severity. So once the patient come to you, how you are going to identify this patient is having acute kidney injury. So you have to get details, relevant history and examination as you did in medical faculty. So I'm not going to into details, you know how to take history and examination. Then investigations and complications of AKI also important, because AKI is just not damaging the kidney, because all our organs are interlinked. So it can cause other complications. So you have to know those things. So investigations, any patient with acute kidney damage, you have to go through basic investigations like blood urea, serum creatinine, and electrolytes, especially sodium and potassium. Sodium can either increase or reduce, and there's a hyperkalemia usually. Do bedside blood gas, so it will show usually metabolic acidosis. And other investigation depend on what your history and examination findings. Chest X-ray, maybe you can detect the fluid overload, pleural effusion, ultrasound scan, any obstruction to the urinary tract, X-ray KUB if indicated. So you have to find the cause and identify the complications. So that's why investigations are important. ECG again, maybe to find out cardiac involvement and hyperkalemic changes. So you can detect from ECG. Then complications, obviously, like urine output is low and there's a metabolic acidosis. Other things like, as I said, hyperkalemia. It is very important to detect. Sometimes you will detect all other complications except hyperkalemia. So hyperkalemia can kill the patient because the patient can go into hyperkalemic cardiac arrest. So it is very important if the patient is having features of AKI, check the electrolyte. And sometimes patients are confused with the uremic encephalopathy. There will be pericarditis. And obviously, lastly, patient can have increased mortality and morbidity. There are some more complications as well. These are the common complications, and it can affect the whole body. So this is the last part of the lecture. Sorry, I will take a few more minutes. So the most important thing, once you detect AKI, no point of just managing AKI without managing the underlying cause. So you have to manage underlying causes actually. Sometimes patient may be having a single cause or multiple causes for AKI. So treat the causes. And especially if the patient is having a pre-renal condition, the hydration is very important. But keep in mind starches, it will directly damage the kidney, so don't use it. Albumin, there are trials, better to avoid at the initial stage of management. When you are doing fluid resuscitation, you can use normal saline. Then blood pressure. So obviously when you manage with the fluid, it will correct sometimes. Sometimes patient may need inotropes. Depend on the condition, you have to use the relevant inotropes. For example, septic shock, then noradrenaline is the first line of inotrope. Likewise, you have to select inotropes. And avoid blood pressure fluctuation, right? Some researchers has shown that single fluctuation of blood pressure significantly damages the kidney. So if there's a hypertension, you assume that the next blood pressure reading will be correct. So it won't happen, right? So you have to act quickly if there's a hypotension or hypertension. Then avoid nephrotoxic drugs. So go through the drug chart of the patient daily, review the drug chart. We don't have pharmacists doing the rounds every day in the ward. So you have to go through the drug chart and identify them, and if possible, avoid and use renal adjusted dose of drugs, especially antibiotic. So you have to do it. And as I said previously, if you want to use contrast, be careful. It can cause contrast-induced nephropathy. So well hydrate the patient before and after using contrast. I used to give normal saline. Some centers, they use sodium bicarbonate. This is also recommended by KDIGO, right? Guidelines. And then, so this is the general management if the patient is having AKI. So any organ, so the fundamental unit of our body is cells. So cell require glucose, oxygen, and nutrition. So that is the basic management. So the recommended target is 110 to 149. Avoid anemia because oxygen is mainly carried by hemoglobin, so you have to correct it. And give adequate nutrition. So this is a common problem in the ward. Patient is critically ill or really unwell. Use neglect about the feeding, nutrition support. Please don't do that. You require the nutrition, so why not patients? They require more nutrition. So and adequate protein. So you are not you are not going to stop giving protein in AKI. You have to give. And always remember to correct potassium. So it is a killer. And if indicated, do renal replacement therapy. So there are some myths like furosemide, it corrects AKI. If there's a fluid overload, you can cure. But not all the patients with AKI, no urine output, you are not going to load with furosemide. And dopamine improves AKI, so it is also again another myth. And protein, you have to give adequate protein, not high protein diet, but adequate protein. So those all are myths. So you take all those things out of your brain and start your internship, right? So a few indications for renal replacement therapy. Obviously, if there's a fluid overload, difficult to correct. And refractory hypokalemia means, so you tried with medical treatment, it is not correcting. So then it is an indicator. And then uremia, especially if they have encephalopathy, pericarditis features. Metabolic acidosis, which is not corrected by medical management. That means not you are going to give sodium bicarbonate in all the patients with acidosis. It is like if there's a metabolic acidosis, like septic shock, they have to give fluids to correct it. So it will correct the metabolic acidosis. Likewise, you try to treat the cause, and if it is not going to correct, severe acidosis is there, that is the indication. And some of the drugs overdose, then again, another indication for renal replacement therapy. There are a few things which is commonly used in our country: peritoneal dialysis, hemodialysis, and CRRT, that is continuous renal replacement therapy. So it is again another topic. I'm not going to in detail. But as a house officer, these are some of the things you have to really consider. This slide is very important, I presume. So usually a decision of renal replacement therapy is taken by your consultant. And then your duties comes. So communicate with the dialysis unit or whatever the unit. And then, so obviously you need dialyzing catheter, VASCAT. Usually peritoneal dialysis is done in the ward. So they are, before putting that, you have to consider about risk of bleeding. So go through again the drug chart, anticoagulant, antiplatelet drugs, iron clotting profile, platelet count, alarm your seniors that if there's any abnormalities. Then get a proper time appointment to take the patient to dialysis unit. And so transportation is another topic. You have to consider how safe patient is transported there. You have to accompany the patient with the monitoring. And sometimes patient can become unstable during dialysis, so you have to use inotropes. So get ready for all those things. So this is one of your jobs, so you have to consider about these things. So this is a figure to highlight renal replacement therapy. I just want to highlight that it mimic the kidney. So dialysis machine try to mimic kidney. CRRT is better than intermittent hemodialysis because it causes more cardiovascular stability. Fluid management wise, it is superior. So disequilibrium syndrome is less with CRRT because it is a continuous renal replacement therapy. So there's no rapid free shift. That is the reason. So the post-dialysis care, so you have to, as an intern, you have to do investigation whether the patient has improved any features of disequilibrium syndrome, and whether the patient required further dialysis or not. And you have to concern about the invasive line also, prevent line sepsis also. So since the time I don't have time, I'm going to skip this slide, but you have to adhere to sterile precautions when you are handling the VASCAT and special peritoneal dialysis catheter also. So this is the last bit. This is a summary of whole thing I said. Like some of the hospital, they have a care pathway for AKI. So if you have alarming that this patient is going to have acute kidney injury, so this is a good care bundle. It is called ACT-BEAT AKI. So the assessment, so it includes all the risk factors, then confirm and staging. So you check the creatinine and urine output, and then so you have to identify the complications, and then do basic investigations, examine urine and drugs, as I said, IV fluids. So sorry, I have to rush through. And the one more thing, the kidney images, if there's an obstruction and infection, so you have to identify it early, otherwise patient can go into urosepsis.
It's okay, you can take your time, because Dr. Lakshmani is getting difficulty in connecting.
Okay. Okay, thank you very much. So then, so you have a vascat. Sometimes patient also having central line, also the same patient. So it is very important. Did I rush this slide also? No. So when you start to put central line, you have to adhere to sterile precautions. Once you start your internship, just observe how your seniors are doing it with sterile precautions. And skin preparation, chlorhexidine is the best skin preparation, but in Sri Lankan settings, we have betadine. That's all right. Initially, there's a guidelines there. The femoral side is more infectious than the other side. So, but it was removed from the guideline. So whatever the site you use to put central line or vascat, if you when you are putting the central line, you have to strictly adhere to the sterile precautions, and until removing it, you have to handle it in a sterile manner, because otherwise this infection is directly going into the major vessel, so it can cause more complications. So that is the main thing. And sometimes you find that in the morning round, as I show, you find that patient is having a fever, but lungs are all right, urine is all right, but you can't find a site of infection. So go through the lines, especially if the patient is having central line or vascat, whatever. So look for features of line infection. There will be redness, tenderness, bit of swelling, maybe in the worst case, post-discharge from the site of insertion. So then you take the cultures, and so, but you should avoid line infection. So these are the things you have to follow, right? So this is the last part of the presentation. Actually, so this is if you Google, you can find various like care pathway. So this is a care bundle. That means you are practicing various things as a bundle at the same time. That will protect your kidney. So this is a summary of the whole AKI whole lecture. So first, so it says assess. So you had to tick whatever the risk factors patient is having. So then C is confirm and staging. So you have alarming that patient is having a lot of risk factors, then you are going to confirm it with the creatinine value, urine output. And then T is treat the cause and complications. So that's what I highlight. So you have to do. Then B is so you can't see it. It is the blood investigation. So we discuss all these blood investigations. So blood gas and other basic investigation, and then examine urine. So sometimes the urine albumin may be present. UFR check the red blood cells. That is what it means. And the urine culture as well. Alter the drug, so go through the drug chart and see what they are on and change it. Daily assess it. Treat with so IV fluids is important. So because dehydration, hypovolemia is a common cause for AKI. And it also mentioned like avoid contrast. So it is very important. Kidney screen mean again doing images, find and try to find out any renal cause like vasculitis, maybe need to take biopsy, blood investigation to check any systemic vasculitis and those things. So that is kidney screen. Images, so this is very important again. If they have a pathology related urinary tract and if they get infection. So urosepsis is another killer. So you have to have, if you have any suspicious, it says, I don't know whether you can see obstruction. If you suspect obstruction and having AKI, you have to do this KUB and ultrasound scan within 24 hours. And if it is a sickness, if the patient is single kidney person, you have to do it with 6 hours because that person is having precious kidney. If you lost it, so it will last forever. So this is a beat AKI. I think you can see this. So this is a whole summary. If you download this and keep it in your ward, so that is a good thing. So I think so it is simple. It is not rocket science. But learn about acute kidney injury. But if you properly do your job, you will protect a patient's kidney. So that is very important because AKI itself can kill the patient. If that patient recovered, sometimes they can have residual damage and they can have chronic kidney disease. So maybe a lifelong dialysis dependent, may need a renal transplant. So you can see how bad it can go, right? So it can change their life forever. So you have to be very careful and manage it. So it is really important to protect patient's kidney. So you have just need to take history examination, investigation, inform your seniors, manage quickly and recover their kidney. So it is very important and it is interesting also, and you will get a lot of job satisfaction if you save somebody's kidney, right? So the take-home message, this is the last slide. So AKI increases hospital mortality and morbidity, and it is a burden to the country. So it is important. And you have to identify underlying cause or causes, and then assess the severity, any complications. And when you are managing, underlying cause has to be treated. Then prevent further exposing the risk factors. And if renal replacement therapy is indicated, you have to prepare and manage as required. So that is the end of my presentation. Thank you very much.
Okay, right. Thank you, Dr. Gayatri.
Yeah.
Informative lecture. So next lecture is by Dr. Lakshmini Pereira. She's getting a little bit late. So there's a message from Dr. Mitraji Premaratna, consultant anesthetist at Ragam Hospital. He will join shortly. So give us a minute. So until such time, anyone's having a question, I'll unmute so they can ask any questions if they're having.
Okay.
So all unmuted. So those who wants to ask questions can ask. I guess no questions.
I think everything is crystal clear. That's why. Then can I leave?
Dr. Lakmini Pereira, consultant anesthetist at Teaching Hospital Anuradhapura. She will start the lecture in short time. Until then, Dr. Mitraji Pemaratna, consultant anesthetist at Ragama. He's a course director for resuscitation Sri Lanka. So he will brief you on the activities on how to do, how to join the training program. So give us a minute.
You're right, training.
Hello, Roshan. Is it all right for me to start?
Yes, madam. Give us a minute. Dr. Mitraji Pemarat is going to have a brief
Okay.
introduction of training, so he'll join shortly.
Fine. Okay. Pulang nih.
Are you there? Right, I think Dr. Mitraji Premaratna, consultant anesthetist at Ragama Teaching Hospital, has joined us. So can you hear? Right. I think we should be okay now. Right. So you can start. Hello. Yes, sir. We have given introduction. You can start, sir. So can you hear?
Can I talk now?
Yes, sir. We have given introduction. You can start.
Hello, good morning to all of you. I would like to thank Dr. Roshan and the Ministry of Health for inviting me for a very brief introduction to the training what we conduct. So all of you are aware that as healthcare providers, we should have valid cardiopulmonary resuscitation certification. We call it CPR certification. The College of Anaesthesiologists and Intensivists of Sri Lanka, we have been conducting CPR training for many years. And from 2012 up to last year or year before, we have conducted CPR training for pre-interns in collaboration of the Ministry of Health. But due to COVID issues and so many other valid and non-valid reasons, we could not conduct it for last 2 years. But nevertheless, we conduct this training for healthcare providers in Sri Lanka at our college training center. So I would like to give a very brief account on the type of training we conduct. So we conduct 3 types of courses, that is advanced life support, immediate life support, and basic life support. And also occasionally we conduct training program under the heading CPR training, but unless you specify the learning objectives, duration of training, training methodology, by itself the name will not tell us anything. So advanced life support training is meant for healthcare providers who regularly care for acutely ill patients. So basically all doctors working in acute medical wards like medical, surgical, gynae, ETUs, ICUs, operating theaters automatically falls into that category. So we are duty bound to provide treatment for sick patients because we work in such places. And also some nurses working in ICU, operating theater setting, ETU will also qualify for such training. So traditionally it is conducted over 2 days. But in Sri Lanka, we have shortened it to 1 day face-to-face hands-on training program and online learning prior to the course. So anybody can register through our website, that is resuslanka.org. Of course, these days we have a huge waiting list of about 250 people because Postgraduate Institute of Medicine has made it mandatory to provide ALS certification prior to the selection exams. So especially those who plan to sit for PGI exams after the internship, so please make some arrangement to do the ALS course prior to your exams. So we also conduct European Resuscitation Council courses, which run over 2 days, that is advanced life support courses. Since 2014, we have been conducted about 40 courses so far and trained many people in ALS set. And we have scheduled 2 courses in September, but we don't know due to COVID situation, we will be able to conduct it or not. So that is about the advanced life support courses. And also we conduct immediate life support courses. So the target group for such courses, mainly the nursing staff, junior medical officers, and doctors who work in community settings like MOHs, some MOPDs, lab-based doctors. So they are not regularly caring for sick patients. And pre-interns and some medical students also qualify to do this immediate life support course. So we teach basic CPR skills like airway, effective chest compressions, safe defibrillation, and ambu ventilation during these courses. And we teach how to be a team member in arrest team. But we don't teach serious stuff like tachybrady management, blood gas interpretation, capnography, team leading skills in immediate life support courses. But as pre-interns or as interns, you can do immediate life support course. So we conduct European Resuscitation Council immediate life support course. That is a 1-day full-time course. Full-time means you have to come physically do the course. Prior to that, usually you have about 1 month to go through the online learning module and do the MCQs. Then you will get a European Resuscitation Council certificate. That is international certificate. Again, if you are planning for overseas work, applying for overseas jobs, having international qualification is good. And mainly we conduct this training in Colombo, but in addition to that, we conduct these training programs in Anuradhapura, Galle, Kandy, Jaffna. Mainly we run it in Kandy and Galle, but due to again COVID situation, some of these training programs came to standstill. So in addition to this CPR training, we conduct immediate life support in obstetrics. Again, 1-day course mainly targeted for those who do gyn and obs. PJM also make it mandatory to provide CPR certification for gynae obs people also, so they can produce immediate life support obstetric certificate for that. So all of you can find details of
So I think there's a connection problem with Dr. Mitraji. So finally, all the details are in the website of College of Anaesthesiologists and Intensivists. So those who are interested, please go to the website. So we'll start the lecture by Dr. Lakshmi Pera, Consultant Anaesthetist at Teaching Hospital Anuradhapura. It's on sepsis, kills and act fast. So over to you, madam. Let's start.
Thank you, Roshan. So can I do my slide sharing? This one. Right. Yeah. Roshan, can you all see? Hello?
Cancer. Yeah.
Everybody, good morning, everyone. So extremely sorry about my this connection problem, and I was late to start this.
Yeah.
Yeah. Okay. So during next half an hour, we are going to talk about sepsis. Why we need to talk about sepsis is because it's a massive problem in current clinical setup, especially among the critically ill patients, because the number of deaths are high and the money that we have to put onto it is huge. So if you take, so even though we are giving everything free of charge here, if you go to foreign country, you will realize how much does it cost. And the other issue that we need to concern about this problem is the mortality. However much you spend on this issue, sometimes the mortality is inevitable. So the mortality risk is very high if you don't diagnose and treat the septic patients early. So have we got Sri Lankan data? What is the mortality rate or anything? So we don't have currently, but we have one study which has been done in a prospective cohort study among 16 Asian countries, where the hospital mortality rate is 44.5, which goes with the universal data. If you take Sri Lankan data, the commonest cause for sepsis is the pneumonia. So you may have realized it with the COVID also, the mortality rate is, the highest mortality rate is reported among pneumonic patients. Among other causes, meningitis and leptospirosis were on the top of the list if you take the Sri Lankan data. So we'll go through a small case scenario. Roshan, is my presentation is clear? Hello? Hello, Roshan? Roshan? Can you all hear me? Anybody?
Yes, madam.
Right, okay. Right, so we have a 63-year-old male. So you are the house officer. So you got a patient in the evening, 63-year-old male admitted to the surgical casualty ward with the complaining of a prick injury to his left foot 2 days ago. Now he is complaining of fever and general unwell feeling. So on your history, you found that he is a type 2 diabetes patient with hypertension in the background medical history. An examination, his temperature is 38, heart rate is his tachycardic 100 beats per minute. He's marginally hypotensive and maintaining blood pressure into 100 by 50. Tachypneic, respiratory rate 25, saturating 95 on room air. Drowsy, but he's arousable. So his limb examination, he has an aggressive looking, warm, tender, edematous limb with blisters from ankle to calf. And he complains of reduced urine output for last 18 hours, despite his poor intake. So as the house officer, we all do this management. So you feel that this patient is not doing well. So we tend to send all the investigation. Likewise, the house officer who was there has sent all the basic investigations, including full blood count and the renal functions, liver functions, especially blood cultures and ABST. And then he has put a IV access, started on fluid, started on antibiotics, and started, since because he is on pain, started on analgesics and antiemetics. So why do you think this situation is now? But what do you think, what made you to do these investigations and do this management? Because you had a feeling of he is not doing well. So he has a early warning. We got an early warning from the patient's clinical presentation. So if we have a way of monitoring his severity, that will confirm our alarm. So we have a tool called early warning score, which is like a modified early warning score, we call it MUSE, which uses to identify the abnormalities in routine observation and to objectify it. Because you feel that this patient is not doing well, but how to convey it to your seniors? You need to have a tool for that. That tool is the MUSE score. or the modified early warning score, which has taken into the count 3 major systems in the body: cardiovascular, respiratory, and CNS. So they have taken certain parameters out of these 3 systems, and they have given 0 mark for the physiological values, and any deviation from physiological values, they have given a plus mark. Sorry. So for an example, if the patient's heart rate is normal, the score is 0. Now, if we can put our patient's data into this score, right? So I will quickly write down the data. So his temperature is 38, heart rate 100, blood pressure 100/50, respiratory rate 20, saturated 95. He's drowsy but arousable. Now we'll put this data into our mu score. So his heart rate is 100. So, okay, we'll keep it at 0 for the moment because it's just 100. Temperature, systolic blood pressure is 100/50. So it's marginally here. So his systolic blood pressure is 100. So he scores 1 for that. Then his respiratory rate is 20. Okay, again, upper normal, but we'll keep it here. It's 20. So he scores again 0. Then his saturation with oxygen, but currently he's oxygenating 95 without oxygen. So we'll put him here, 0. So his temperature is 38, again 0, and he's drowsy but arousable. So he comes somewhere here, verbally or to the painful response, he is arousable. So we'll put it as 1. So overall, his mu score is 2. Even though you feel that this patient is not doing well, once you put those parameters into the mu score, okay, patient scored 2. Now we'll see what we can do with this mu score. So depending on the mu score, the number, your action depends. It depends on 2 parameters. One thing, what you are going to do with it, to whom you are going to inform it. So if your score is 1, so it's all right to monitor. So the patient, it's not normal. Patient is having some abnormality, but you can wait for 4 hours, 3 to 4 hours, and monitor again with your management, because you have started some management now at the ward level. And you can wait. Even you can ask the nurses to do the muse charting in another 3 to 4 hours. If your score is 2, starting score is 2, you can't wait till 4 hours. So it's better to start monitor him again with the mu score in another 1 or 2 hours. But if your mu score is 3 to 5, that means there's something significantly abnormal. So you need to monitor the patient. At the same time, you need to inform this initial mu score to your seniors. It could be your registrar, your senior registrar at this moment. So you can say, look here, I got a patient like this. Since I felt not normal, so I put the patient in the mu score, and his initial score is 3 to 5, 3 or 4. But if the initial mu score is more than 5, this patient is having very high risk of going into sepsis or getting bad within next 1 hour. So you need to immediately inform, and you need to contact your ICU team early. Right. So that is how you continue with your mu score. If the mu score has a score more than 5, or any single score scoring more than 3, there is a high sensitivity. This patient is going into sepsis somewhere around 79 to 80%. Right. Now you are waiting for this next monitoring, since because your mu score is 1 or 2, you have like 3 hours to see what has happened with your management. So during that time, you received your investigation. So the WBC count is high. Okay, your suspicion is correct. He is having some infection. CRP is high. Again, confirmatory. And the UFR shows plus pus cells. Again, your suspicion is confirmed. Creatinine, urea, liver function, and cultures are pending. Other things are currently normal. And you have the facility, you have done a blood gas where there is a mild metabolic acidosis, pH 7.1, CO2 31, Oxygenating, okay. Right. So your nurse has done, as you have instructed, your nurse has done the second assessment after 3 hours without waiting for 4 hours. So we'll put this again into the Muse chart. Now the systolic blood pressure is 80. So now he's scoring 2 for the systolic blood pressure. And the heart rate is now 120. So again, he is scoring 2 for the heart rate. And now the respiratory rate is 30. So he is scoring 1 for that. Now he is using oxygen, if you can see here. Now he is using oxygen via nasal prongs and saturating 94. So now he is somewhere, okay, we can say 1, we'll put it 0, but still now he is using oxygen. And temperature now 38.3. So he is scoring 1 for that. And he is still arousable. So he is scoring 1 for that. So altogether now his score has 2, 4, 5, 6, 7. His scoring has risen up to 7 from 2 within 3 hours. So your suspicious was correct and the patient is getting bad. So as we have discussed, as you have suspected, what is the diagnosis? Sepsis. So what is sepsis? Sepsis is a very common clinical situation if you know how to diagnose it early, because if you diagnose it late, the mortality rate is very high. It is a life-threatening organ dysfunction caused by the dysregulated host response to the infection. So the important wording here, it's life-threatening and it's a dysregulated host response, because we all get immune response to any kind of infection. But once this immune response gets dysregulated, the patient will go push into sepsis. Initially, in 2010-15 time era, so there were like various nomenclatures and definitions for sepsis. So they have SIRS, sepsis, severe sepsis, and septic shock, where we don't use those definitions at the moment. We use the sepsis is life-threatening organ dysfunction caused by the dysregulated host response to the infection. And you call it septic shock if the patient requires vasopressors to maintain the blood pressure more than 65, and blood lactate goes more than 2 millimoles per liter. So actually, septic shock is a subset of sepsis patients. So if you diagnose, so your early warning score is high, so you quickly put the patient into sepsis criteria. And if you diagnose sepsis, the initial mortality more than 10%. And if you diagnose septic shock in the patient, in these patients, the mortality rate goes more than 40%. So why this dysregulated host response takes place? So any infection, there is an inflammatory response mounted, self-mounted from the body. So it could be due to the initial injury, to the microbe itself, or to the toxin. This is a complete interaction between the pathogen and the host immune system. The physiological response is to localize the infection and take it away from the circulation or the body. But when it comes to the sepsis will trigger the inflammatory and pro-inflammatory and anti-inflammatory both pathways. That is why it is called the dysregulatory system. So because of the activation of the pro-inflammatory pathway, there will be a gush of inflammatory cytokines like TNF-alpha, leukotrienes, lipoxygenase, histamine, bradykinin, which will give rise to the clinical picture. At the same time, because of the activation of the anti-inflammatory pathway, it will result in a negative feedback mechanism. So activating both together, that will give rise to a clinical picture of sepsis. So what is the clinical picture of sepsis? At last, they will do vasodilatation, which causes severe dropping of the blood pressure. They will cause leaking of the volume. So they will develop edema and hypovolemia. And because of the activation of the anti-inflammatory pathway, they will form microinfarction. So altogether, they will give rise to the clinical picture of sepsis. For this leaking part, there's another theory in pathophysiology. We call it glycocalyx theory. Glycocalyx is a matrix, endothelial matrix with lining endothelial cells in the vasculature, small vessels, serving as a barrier opposing to the vascular permeability and limits the transvascular movement of the fluid. With the sepsis, degradation in sepsis with the inflammatory cytokines, this glycocalyx get damaged and the fluid leakage we can't explain with our normal hydrostatic conchotic pressure gradients. Right. So why we always say it's always spot it early? Why it is difficult to spot it? Because it has a various clinical phases. Because if you detect it very early phase, the clinical picture will be different. If you diagnose the patient at the time of septic shock, the clinical picture will be different. So how do you do this assessment? Now, you spot your patient thinking that he's not doing well with the assessment, like with the Muse score chart, and now you have a high suspicion since the Muse chart score is high, whether this patient is septic. So how to diagnose quickly whether the patient is septic? For that, we have the QSOFA tool, which is a bedside screening, very simple and quick. So on-board you can use it. Where you have 3 criteria: respiratory rate more than 22, our patient's respiratory rate is more than 30, altered mental state, yes, our patient is having that, systolic blood pressure is less than 800, yes, so our patient is positive for all 3 out of 3. So he's in sepsis. So easy way to remember these 3 is the HAT, the mnemonic HAT: hypertension, altered mental state, and tachypnea. So if you diagnose, if you have 1 or 2 points, the risk is low, but if you have 2 or 3 points, the risk is high, very high for a poor outcome. So quick SOFA is derived from the SOFA score, which uses almost all the parameters from almost all the systems, and which is a very comprehensive one. We normally don't use it for the diagnosis of sepsis. Right. Now my patient is in sepsis. So now I want to find out whether my patient is in septic shock. To say he's in septic shock, he requires vasopressors to maintain more than 65 and the lactate has to be more than 2 according to the definition. So if you can remember my ABC, lactate was 8.3 there and systolic blood pressure is 80. So my patient is almost all in septic shock. So if the patient goes into septic shock, sepsis is a multi-organ involved condition. So the patient will develop, show the clinical picture involving almost all the systems. The lungs will go into ARDS, CVS refractory hypertension, patient will go into renal failure. So it will slowly invade one after the other systems in the body. So we have no time. We have to act quickly. So what is the management? Currently available best evidence-based management is given by the Surviving Sepsis Campaign guidelines. So you can Google this and you can get it. So it will reduce the mortality. It's evidence-based to show the reduced mortality due to sepsis. Requires an organized process with various clinical interventions. So it is updated continuously. So current update, what we are using currently is 2018 updated Surviving Sepsis guideline. Because it's because it's a medical emergency and you have to resuscitate these patients very fast. So the resuscitation, we call it a resuscitation bundle or sepsis bundle. So what is a bundle? Bundle is a group of interventions. We implement them together within a specific time frame. Right. So what is the specific time frame here? As soon as you diagnose sepsis or septic shock, you have to implement this bundle, septic bundle, within the first hour. So what are the components of the bundle? Take culture and then start on broad spectrum antibiotics, measure lactate, volume resuscitate, apply vasopressors. We'll go one by one. So initial resuscitation. So how you can go up to 30 ml per kg, which is a huge amount over 3 hours. So you can give it as boluses. Normally in clinical practice, what we normally do, we give 250, 250, 250 boluses at certain gap and monitor the patient's volume responsiveness and the improvement. And you can go these boluses totally up to 30 ml per kg. The two important groups that you have to very cautious with here is the elderly people and the patients with heart diseases. So that is the amount. So what is the fluid? So crystalloid is the preferred one. Normally you don't take albumin. You can take albumin, but crystalloids are the preferred solution for initial volume resuscitation. So you can go for conservative over liberal fluid status. So these are the changes. Sorry, we'll skip this slide. Right. So now we have started volume resuscitation. So we have started giving fluids and we have started monitoring the cardiovascular status of the patient. Next, you take the cultures, all possible cultures. These cultures has to be blood cultures and any sample that is suspicious of. It could be urine, tracheal secretions, sputum, wound subculture, whatever it is. So if you are taking blood cultures, take 2 blood samples, separate from 2 separate sites with few gaps apart. That is the ideal, but what normally we do is we take just 1 blood sample, but that is the ideal. So that culture taking has to be done before the starting of antibiotics, because even with the first dose of antibiotics, the blood can be sterilized. So there's no point of taking blood cultures after giving antibiotics. So take the cultures before starting antibiotics. Then hit the patient with antibiotics. So we call it hit hard and hit quickly. So we have 2 types of antibiotics. We have concentration dependent antibiotics and we have time dependent antibiotics. Concentration dependent antibiotics, they are like single daily doses and you give it a big dose. So the best example is aminoglycoside or the gentamicin. So you give it 5 milligram per kg. So it's a daily dose. Time dependent killing, you need to maintain a certain concentration, blood concentration of the antibiotics over a period. So these antibiotics are given in frequent doses. So the cephalosporins, meropenem, piptas, most of the antibiotics fall into time dependent killing. And you need to start the antibiotics depending on the pathology. So we call it empirical combination of the antibiotics. So if it is a bowel pathology, whether it's a urinary pathology, it's a CNS pathology, your empirical antibiotic therapy differs. Normally, within 24 to 48 hours, you continue with your antibiotic therapy, empirical antibiotics. And once you get your culture reports, you have to escalate or de-escalate your antibiotic therapy. Normally, the empirical antibiotics are not continued more than 3 to 5 days. So combination of antibiotics are with patients who are in septic shock. So procalcitonin is a good guidance for you to discontinue your empiric antibiotics and to decide on antibiotics. Now since now you have diagnosed this patient is critically ill and you have diagnosed septic shock in this patient, you have quickly informed the ICU team, started on oxygen, cultures were taken, started on empirical antibiotics, and the ABG was done, where the lactate was 8.3. And you have repeated fluid boluses over 2 liters over 1 hour, and repeat lactate is 6.7. So you feel that this patient is, you realize now this, you can't manage this patient alone. Now almost all his organs are going down. So you need ICU care. So you talk with ICU people and admitted to the patient to the ICU. So there, since the patient was in septic shock, they have put an internal jugular line and started on noradrenaline. and increase accordingly to get the MAP more than 65. And all the systems are being monitored, and lactate levels, urine output, and continuous cardiac output were established. And patient is currently on high flow 15 liters oxygen, but saturating only 95. Okay, whether to intubate. EC's respiration is going to affect it. We'll keep that part. Now, in the bundle, next thing is the vasopressors. Now, we said once the patient was admitted into the ICU, patient was started on noradrenaline. So what are the vasopressor choice in sepsis? So you have noradrenaline, adrenaline, and vasopressors. Dopamine and dobutamine. Dopamine only recommended in highly selected patients. Dobutamine is recommended if it is indicated. Patients with cardiac diseases, patients with Takotsubo condition, because the demand is so high. So you need to like put some dobutamine into it, not only the vasopressors. So the first choice of vasopressor is the noradrenaline. So the dose is 0.01 to 0.5 microgram per kg per minute. Adrenaline, same dose. Vasopressin, very low dose, 1 to 4 units per hour, escalating to achieve your targets. Right. Now you have volume resuscitated in the ICU. You have started on antibiotics, taken cultures, started on vasopressors. How to check the volume resuscitation, when to stop it? Now, fluid status. Clinically, you can do this with the improvement of the blood pressure, slowing down of the heart rate, improving of the arterial oxygen saturation, slowing down of the respiration if the patient is breathing spontaneously, capillary refilling, and the very good thing is the urine output. Or if you have the facility and if you are skilled enough, you can do these things. So Caval index, stroke volume variation, or cardiac out bedside cardiovascular ultrasound, and CVP measurement, and the mixed venous oxygen saturation. Right. After your volume resuscitation, lactate is a very good indicator to show whether your volume resuscitation is adequate, because lactate is produced by the tissue hypoperfusion. So if your volume resuscitation is adequate and your blood pressure is restoring back to normal, your lactate should go down. And the important thing about lactate is lactate shows a linear proportionate correlation with the mortality. If the lactate goes high, severe the septic shock, and the mortality is very high. So the early clearance of lactate with volume resuscitation, vasopressors, and other measures is important. Right. If you can remember, I said the bundle of resuscitation, bundle is a set of interventions implement at once over a period of time. Okay, what is the period of time that you are waiting for? Normally 4 to 6 hours. And you need to have target achievement during these 4 hours to see whether your patient is improving or deteriorating with these interventions. So if the CVP is maintaining 8 to 12, MAP maintaining more than 65, producing urine more than 0.5 ml per kg per hour, mixed venous saturation more than 75, and the lactate is coming back to normal are the prognostic indicators you need to achieve with your resuscitation during the first 6 hours. Right. Have we missed anything from the bundle? Yes, the surgical clearance. So it is very important to see whether the patient is having a clearable source of infection somewhere. So if it is there, you need to remove it. Otherwise, there's no point of doing all this management. So it could be surgical, it could be percutaneous, whatever the least invasive way, you need to do the source control. Right. Apart from the main bundle, there are some supportive care. So once you put the bundle into in practice within first hour, you can think about the supportive care. So what is the role of steroids in sepsis? So steroids are only used in patients who are refractory to volume resuscitations and vasopressor therapy. Normally in clinical practice, what we normally do, if the patient is refractory to volume resuscitation, requires 2 or more than 2 vasopressors to maintain blood pressure, you think of starting steroids. It is hydrocortisone 50 milligram QDS, or you can start it as an infusion 200 milligram per day. And if once the patient is improving with septic shock, you have to stop it. Place of blood transfusion. If the hemoglobin is less than 7, you need to think of giving blood because the oxygen delivery to the tissues has to be optimized. FFP, you are not treating the lab reports, but if unless the patient is showing any evidence of bleeding, you don't treat lab reports and you wait for the correction. Platelet, again same. If the patient is bleeding, regardless of if the patient is not bleeding, but the platelet count is less than 10,000, regardless of bleeding, you tend to give platelet. If it is more than 20,000, if the patient is having bleeding risk only, you are transfusing platelets. But if you want to do a surgery or invasive procedure, you need to keep it more than 50,000. Glycemic control is very important because these patients tend to go into hyperglycemia as well as hypoglycemia very frequently. So you need to monitor at least hourly. And your target sugar has to be not hypo, not hyper. So normally in clinical practice, it's 100 to 180. You need to maintain with best ways to maintain it with insulin infusion. If the patient is intubated, you need to think of sedation and paralysis if it is indicated. If the patient goes into multi-organ dysfunction, so pulmonary, if the patient develops in ARDS, follow the ARDSNet protocol with minimal tidal volume ventilation with permissive hypercapnia. If the patient goes into renal replacement therapy, consider hemodialysis or CRRT. As Gayatri said, we need to think of nutrition very early, whether it could be enteral or parenteral. Think about deep pain prophylaxis and stress ulcer prophylaxis and bicarbonate. This is a common thing that we normally do. Bicarbonate therapy for the purpose of improving hemodynamics or reducing vasopressor requirement is not recommended for the treatment of hyperperfusion-induced lactic acidemia. Simply, if the pH is more than 7.1, even though the patient is acidotic, we normally don't give bicarbonate because it can cause refractory intracellular acidity. Vitamin C, clinical evidence says yes, but normally we don't do it in current practice. So how is our patient now with all this resuscitation? So the blood pressure has picked up with noradrenaline and 4 liters of fluid. Urine output is marginal still, and he's adequately volume filled, IVC full, and adequately filled ventricles. Because the volume resuscitation is optimized, thought of like starting second inotrope, the vasopressin, and sugar was monitored and managed. Hydrocortisone was started because the second inotrope was started. Despite the rise of MAP, the patient's acidosis is remaining same and the renal function is going up. So the CRRT was considered and source control was considered, and metabolic acidosis is getting improved, and the general ICU care, supportive care was given. Over the days, patient's vasopressor requirement has come down, urine output has improved, and the patient was gradually weaned off from the ventilator. And by day 12, all the supports were stopped and he was discharged. Right. That is how we need to manage sepsis. So in summary, it is very important to go for early diagnosis, early implementation of MuSCO, early diagnosis of sepsis and septic shock, and continue to monitor. Once you have a feeling this patient is not doing well, put the patient under the MuSCO and continue to monitor. And once you diagnose your sepsis, early resuscitation and implementation of resuscitation bundle as early as possible will save the lives, and supportive care. And to do the volume resuscitation bundle, it is volume resuscitation, inotropes and vasopressors, source control, cultures and antibiotics, steroids and lactate. And think about supporting all the systems, nutrition, DVT, glycemic control, stress ulcer prophylaxis, renal replacement, ARSNet protocol, and sedation. It's very important. So the sepsis is, septic patients are deteriorating very badly. So you need to communicate with the patient's relatives very early, because you may have a very small period to play around. So we never know which side the patient is going into. So communicate with the patient's relatives very early. And we, even though we don't have end-life care or palliative care protocols, if you are going to work in a foreign country, you may have to think about these things as early within first 72 hours of admission to the ICU. So you may have realized early recognition is the key for the management. So time is the factor. So diagnose it early. So what is the time zero? What is the time for the act? Is it the time of diagnosis? Is it the time of you inform to your consultant? Is it a chart-based thing? So what is the truth? It's a balance. So routine screening or monitoring the patients with Muse chart is very important in this setup. And remember, you can't manage these patients alone. It's a multidisciplinary team approach. You need everybody's help to do these things. So sepsis is a fast killer. Unless you act fast, faster than sepsis, you can't save your patients. Thank you very much. Right. Okay. So if I have time, is it all right to go through these questions? We'll take, so one first, okay. Okay. First question. Can you please tell the definition of sepsis? So I think, okay. Sepsis and septic shock again. So sepsis is a dysregulatory host immune response. Septic shock is a dysregulatory two inotropes to maintain the blood MAP more than 65 and the lactate rising more than 2. Roshan, is it all right to continue with few questions?
There are some questions on the chat box. I think Dr. Sushil Jayatulake is there to next lecture. You can answer them on the chat box. So can we go?
Yeah.
Right. So we are short of the time schedule. Right.
Thank you very much, Roshan.
So we can start the lecture. Yeah, thank you very much, madam. Right. So we can go to the next lecture by Dr. Sushil Jayatulake, consultant anesthetist at LRH. So can you hear?
Yeah, I can hear. Yeah.
Yeah. Okay. Over to you.
Okay. Good morning, everybody. Sorry that we couldn't give you a break. Anyway, we'll continue my lecture and then yeah. Can you hear me now?
Yes, can hear. Can hear.
Okay. Okay, can you see my first slide?
Not yet.
Okay. I'm finding it difficult to share my screen at the moment.
So I log in from a Apple or normal?
No, it's a Samsung phone. Just a moment, please. Yeah, do this. Can you see it now? Can you
Not
see
yet,
my?
sir.
Okay. Now can you see the screen?
Yes, but yes. Yeah, okay.
Yeah. So can you see the topic shock and inotropes?
Yeah, can see, sir. Yeah.
Is it clear? Is it clear?
Yes, yes, yeah.
Okay. Okay. So we'll start. Again, my name is Dr. Kusita Jayatilika. I'm working at LRH. So we are talking about today basically shock and inotropes, and also we are going to discuss about vasopressors and fluids a little bit. So these things are very important for you when you are working in the hospital as a house officer or in your post-intern period as well. So first you should be able to identify what is shock and what are the features of shock. So on definition, the shock is inadequate tissue perfusion. So obviously it is life-threatening condition. So how do you identify clinically whether a patient is in a shock? When the blood supply to the vital organs is reduced, or when there's lack of tissue perfusion, obviously you will get features like, for example, if the blood supply to the brain is reduced, the orientation of the patient and the conscious level can go down. And if the blood supply to the kidney is reduced, then urine output will be go down. And it's same for any organ. For example, to the heart, it will cause ischemic changes in the ECG or even chest pain. So these are the features of shock. So it's basically inadequate tissue perfusion, which will be clinically manifested by features related to those particular organs. So it can be broadly divided into 4 types. The first type is hypovolemic shock. The second type is cardiogenic shock. Third one, obstructive shock, and the last one is distributive type of or vasodilatory type of shock. So these things are basically the things that we have learned in our medical school. So if we can go through again, the first type of shock is hypovolemic shock, where there's a volume loss from the cardiovascular system, and the examples would be things like any type of hemorrhage, or any thing like such as diarrhea or severe vomiting even. So you can get hypovolemic shock. And the second type is cardiogenic shock, where there's no problem with the volume status, but the problem is with the pumping action of the heart. So whenever there's a problem with the pumping activity of the heart, for example, when there's a myocardial infarction or myocarditis or cardiomyopathy, anything that is affecting muscle of the heart, you will get a cardiogenic shock. The third type is if something is obstructing the blood flow in the main vessels, for example, to the IVC. If the IVC blockage does not allow the blood coming into the heart as a venous return, for example, in tamponade or tension pneumothorax, or even in valvular stenosis. So there's, or even in pulmonary embolism, when there's a huge obstruction to the blood flow, then you will get again a shock which is called obstructive shock. And finally, distributive type of shock is mainly due to sudden vasodilatation, where there's a relative hypolemia because of sudden vasodilatation. For example, in sepsis, you will get a vasodilatation. In anaphylactic shock, you will get a vasodilatation, and neurogenic shock due to the damage to the spinal cord, where you will lost the sympathetic tone into the vessels, so you'll get a neurogenic shock. So these are the 4 types of shock. I have highlighted in the red color the cardiogenic shock and the distributive shock, because these are the 2 types of shock where you need the inotropes or vasopressors mostly. And then we are moving to the next slide. Can you see my slides? Can you see my slides? I hope you can see my slides. So so this is basically a slide which is telling you a formula, a very familiar formula, where the blood pressure, the factors that is going to affect the blood pressure is mainly determined by 2 factors. The first one is the cardiac output, and the other one is the systemic vascular resistance. So when the cardiac output increases, obviously the blood pressure has to go up, as well as when the systemic vascular resistance is high, or else, in other words, when the caliber of the blood vessels is smaller, if it becomes constricted, the systemic vascular resistance will go up. That will again increase the blood pressure. So blood pressure is basically a product of cardiac output and systemic vascular resistance. And the next one is the inotropes. So you are well heard about inotropes, but probably you might not know what is the definition of the inotropes. It's any drug or chemical substance that will increase or decrease. In other words, something that alters the contraction, the force of contraction of the heart is called inotrope. So there are 2 types. The positive inotropes are the ones that will increase the contractility of the heart, and obviously the other one is the one that will reduce the contractility of heart. So the examples of the inotropes, positive ones, are the dobutamine and adrenaline and dopamine, and the negative inotropes are, for example, calcium channel blockers and beta blockers. We are going to talk about positive inotropes today, and the positive inotropes are the things that we are usually called as inotropes. So when somebody calls inotrope, it implies a positive inotrope. So how the inotropes will increase the blood pressure? So if we go back to our formula, blood pressure is a product of cardiac output and stroke volume. So when the inotropes increase the contractility of heart, it will increase the stroke volume, thereby it will increase the cardiac output. So when the cardiac output is increased, according to this formula, the blood pressure should go up. So again, the examples of the positive inotropes are given here: dobutamine, adrenaline, and dopamine. Although in our topic we have not mentioned about vasopressors, is also very important drugs. I think this topic should be called as inotropes and vasopressors, because, for example, noradrenaline is not an inotrope; it's a vasopressor. But generally, when we are talking about inotropes, we also talk about noradrenaline, although it is a pure vasopressor. So how vasopressors are going to help you in control of blood pressure? So it will increase the systemic vascular resistance. So if you go back to our formula again, the blood pressure is a product of cardiac output and systemic vascular resistance. So systemic vascular resistance can be increased by vasopressors by squeezing of the blood vessels, or reducing the caliber of the blood pressure, the blood vessels, or in simple terms, by the constriction of the blood vessels. Yeah, sorry about that. Let me go back. Yeah. Okay, so we are talking about vasopressors now. So the examples are drugs like noradrenaline and vasopressin. Okay, so we should know some idea about the receptors. So receptors are the target places of the drugs that we are giving, or the target of the inotropes and the vasopressors, or in other words, the places where the drugs are going to act in the cells. This is basically a very theoretical knowledge. So there are many receptors, for example, alpha 1, alpha 2, beta 1, beta 2, and V1 receptors. So some of them are found in the blood vessels, and some of them are found in the heart, and some of them are found in other places like in brain and in bronchi as well. So so there are many receptors, and different inotropes and vasopressors will be act on different receptors. Based on that, their clinical implications would be different. So this is the most important thing clinically. So when you're working in the clinical setup, in the ward, in the ETU, or in the OPD, or the PCU, or in the ICU, or in a place. So we'll talk about some clinical scenarios where it will help you to choose the correct inotrope or the vasopressor depending on the clinical scenario. The first scenario, I'll read that for you, is a 25-year-old boy with no significant past history, admitted to accident and emergency following a road traffic accident. Now he is having a cold, clammy pulses. The pulse rate is high, it is 120 beats per minute. Blood pressure is quite low, 82/68. You can appreciate, I think the blood pressure is 82/68 with a low pulse pressure. The pulse pressure is the difference of systolic and diastolic blood pressure. Here it is about 14. That means he is having a constricted type of vasculature at the moment. That's why he's having thready and rapid pulses. And the ultrasound scan has revealed the liver is lacerated. So liver laceration has caused a lot of intra-abdominal bleeding, and that has made the patient go into hypovolemic shock. So it is an emergency situation. So that's the thing that you have to realize when you are managing the patient. So when there's an emergency situation, you have to call everybody for your help. You have to call your seniors. You have to call probably the theater. You have to call the radiologist, the anesthetist, or any person that needs for you to manage this patient. So every emergency situation, you have to go by ABCD approach, the airway, breathing, circulation, like that ABCDE approach. And when you do that at circulation, at C, you identify the problem is the circulation. The problem is with the circulation. You find the blood pressure is low, and you realize the problem for the reason for the low blood pressure is hypovolemia. So when the volume status is low, you have to give adequate amount of fluids. So when you have giving fluids, and when the blood is ready, you can give blood and blood products. So you can resuscitate with volume. And when you have resuscitated with volume, the patient hypovolemia will be over, and the patient will be normovolemic, and your problem is over. And probably you have to bring this patient to the theater to achieve hemostasis. Probably you have to do some repair, and you can manage this patient successfully. So do we need to give vasopressors or inotropes in this kind of patients? Probably not, but while you are giving fluids, while you are giving blood and blood products, if the blood pressure is still low, we have to protect the brain and we have to protect the heart. So you have to keep some sort of reasonable blood pressure. So you might have to use vasopressors such as noradrenaline or adrenaline as a inotrope to achieve your target blood pressure until your volume status is good. So similar scenarios can happen in things in like in obstetric wards with postpartum hemorrhage, or in medical wards with diarrhea. We'll go into the next clinical scenario where there's a 64-year-old smoker with a past history of hypertension presented to the cardiology unit with tightening left side chest pain. Pulse rate is 92 and blood pressure is quite low, 74 or 46. And ECG, when you're doing ECG, you find the patient is having ST elevation MI. So again, when you're managing this patient, it's an emergency situation, you call for help and you go for ABCD approach. And when you identify at circulation, you find there's a problem in the circulation. The problem is low blood pressure. The reason for the low blood pressure is pump failure, or there's something wrong with the myocardium. So how to deal with? So you have to give some thrombolytic agent to restore the blockage, but until then you have to resuscitate the patient. You have to support the heart. You have to give a positive inotropic agent for the remaining muscles of the heart to act better. So you are basically stimulating the rest of the heart muscles with a positive inotrope. So you can start dobutamine. Probably you can give a fluid bolus before you start the inotrope, but be careful, the patient might be in heart failure with a lot of crepitations. So you might, there may be a chance that you might be able to give a little bit of fluids before you're starting your dobutamine. Similar scenarios you can get in cardiomyopathies and myocarditis as well. So we'll talk about dobutamine. It's a synthetic inotrope. It's mainly stimulate beta-1 receptors in the myocardium, and you can start is as an IV infusion through a syringe pump. You can go up to 20 mics per kilogram per minute, and you can prepare this medicine in a 50 ml syringe with normal saline. And you have to have a central venous catheter or CVP line to give this medicine. But until such line is available, probably you can start this medicine with a good large bore venous cannula. But this, as any other medicine, it has its own side effects. So systemic vasodilatation, tachycardia, and arrhythmias are some of the side effects of this medicine. So it is metabolized by monoamine oxidase system as well as catechol-methyl transferase system in the body. And we'll go for the next clinical scenario now, where there's a 72-year-old lady with a history of diabetes mellitus admitted to the medical ward with fever, cough, and altered level of consciousness. And her pulse rate was 104 and blood pressure was 76 over 32. Again, here you can appreciate that the pulse pressure or the difference of systolic and diastolic blood pressures are high here because of systemic vasodilatation. So this patient is basically having a sepsis. We have discussed about sepsis in the previous lecture. So its vasodilatation is a basic problem. So that's why the blood pressure is low. And when you have performed a chest X-ray, it has revealed the patient is having pneumonia and sepsis is the cause. So diagnosis is sepsis. So how to manage? Again, you have to go through ABCDE approach, and at circulation you find that the blood pressure is low, and the reason for the lower blood pressure is systemic vasodilatation and reduced SVR that has caused low blood pressure. So how to deal? You have to give plenty of fluids, generous amount of fluids up to 30 ml per kilogram, and if that fluid amount does not restore the blood pressure, then you have to think about a vasopressor. So the vasopressor of choice in septic shock is noradrenaline, and the second line drug is vasopressin. So with those, you can counteract the vasodilatation and the blood pressure would be stabilized. A similar sort of vasodilatation you can get in anaphylactic shock as well as in neurogenic shock. So let's talk about noradrenaline. It's the first line choice in septic shock. It's an endogenous vasopressor, means that it is being produced in the body as well. It's mainly alpha-1 receptor stimulant. So alpha-1 receptors are found in blood vessels. When it is stimulated, it will cause vasoconstriction and it will increase the SVR or systemic vascular resistance. So it is again being prepared in 50 ml syringes with normal saline, and doses you can give up to 6 mics per kilogram per minute. But be careful when you are giving, when the dose is increasing, you can get systemic vascular resistance going up. Excessive vasoconstriction can cause necrosis of tissues, especially in the peripheries. So you can see your toes and your fingers, the tips are becoming black in color. So at that time, you should not increase it more. Actually, you have to reduce the dose. The other side effects include bradycardia and arrhythmias. Again, it is metabolized by monoamide oxidase and catecholamine methyltransferase system. So this is a drug that will cause vasoconstriction. So definitely you should not start this with a peripheral line until a central line is available. So it is the ampule of noradrenaline looks like this. It is mentioned as 4 milligrams of noradrenaline tartrate. So if you remove the tartrate part, it has only 2 milligrams of pure noradrenaline. So it's actually 2 milligrams. Coming into vasopressin, vasopressin is a hormone. It's also called antidiuretic hormone or ADH, being produced in the hypothalamus and stored in the posterior pituitary. It's a naturally occurring hormone. It's a potent vasoconstrictor as well, in addition to its antidiuretic action. So it's second line drug in noradrenaline, to noradrenaline in sepsis, and you can give up to 0.04 per minute IV infusion. You can again dilute this drug in normal saline. The side effects including hyponatremia and bradycardia. It is metabolized in some other direction, in other place, in liver by proteases. So you can start this medicine via peripheral line until the central venous catheter or CVP is available. So this vial looks like this. It comes in 20 units per ml solution. Let's go for our final scenario, where there's a 32-year-old lady admitted to probably PCU after a dog bite, and she was given ARS. And after ARS, the lady is complaining of faintishness. And when examined, the pulse rate was 92 and blood pressure was quite low, 72 over 36. And she has also developed erythematous generalized rash. And if you auscultate, probably you might be able to hear some bronchi as well. So diagnosis is anaphylactic shock, where you have to act very quickly. It's an emergency situation. You have to call for help. You have to go by A, B, C, D, E approach. And at circulation or at C, you identify the patient is having acute vasodilatation and reduced blood pressure, and the reason is vasodilatation. It's a vasodilatory type of shock due to reduced SVR. So how to deal? You have to keep the patient flat. You have to raise the legs to support auto transfusion or transfusion of blood from the legs into the vital organs. And you have to give ample fluid bolus, like 500 to 1000 ml you can give. And drug of choice here is IV adrenaline, 1 mic per kilogram. If you don't have IV access, you can give 1 milligram of adrenaline IM as well. So in all the previous clinical scenarios, we gave the inotropes or vasopressors by an infusion, but here you have to give it not as infusion, as a bolus. So adrenaline is a naturally occurring catecholamine. It's being produced in the adrenal medulla in the body. it is very popular drug as well as a cheap drug. And it stimulates all the receptors alpha 1, alpha 2, and beta 1, beta 2. So at different infusion rates, it will stimulate different receptors. So at relatively lower dose, for example, up to 0.1 mics per kilogram per minute, it will mainly cause vasodilatation and tachycardia and inotropic action. But when the dose is going up, it will cause vasoconstriction. So if you start at a lower dose, probably you can start this drug via peripheral vein, but definitely you have to have a central line or CVC line later on to continue the drug. It's again being prepared in normal saline in a 50 ml syringe. The side effects includes tachycardia, palpitation, arrhythmias, and tremors, metabolized by monoamine oxidase and catecholamine methyltransferase systems. So this is the adrenaline vial. It comes as 1 milligram in 1 ml. I'm sorry, this is not a vial, this is an ampule. So 1 milligram in 1 ml, or we call it 1 in 1000 solution. Finally, we talk about something about dopamine. It's not being regularly used. It's not a first line drug, but you have to have some knowledge about dobutamine. It comes in a vial. It's a positive inotrope. It has some bad side effects like arrhythmias and tachycardia. Again, you have to start this medicine in a peripheral. You can start it with the peripheral line until the central line is available. So we'll talk about some of the general rules when you are using vasopressors and inotropes. So you have to identify what type of shock the patient is in, and you have to match your inotrope or the vasopressor to the type of the shock. And then you can give a bit of fluids before you start your inotrope or vasopressors. Definitely in hypovolemic shock, you have to restore the volume status, is the prime thing in hypovolemic shock. But in cardiogenic shock, you should be extra careful when you are giving a fluid bolus before you are starting inotropes, because of the worry of pulmonary edema due to left ventricular failure. So inotropes and vasopressors need to be given via central venous catheter, but practically in the ward setup or in other setups, you might be able to start in a peripheral good large bore with a large bore cannula in a good large vein until you organize for a central venous catheter. So when you are starting an inotrope or vasopressors, you have to have a multipara monitor. You have to continuously monitor the patient, the respiratory rate, saturation, CVP, and intra-arterial blood pressure with the arterial line, and urine output and blood gases. You have to monitor them continuously when you are using an inotrope or vasopressor. And you need to run the inotropes or the vasopressors through a syringe pump with an on dose. And you have to anticipate side effects of these inotropes. For example, the arrhythmias, myocardial ischemia, peripheral tissue necrosis, and electrolyte imbalances. So we have to anticipate those side effects. So with that, I conclude my lecture. Yeah, there are some questions. I don't know whether enough time is available for me to answer them.
Yes, sir, we can ask few questions.
Okay. All right.
What is the normal range of for blood pulse pressure? Was one question.
Okay. So pulse pressure is the difference between the systolic and diastolic blood pressure. So if you consider the normal blood pressure as 120 or 80, it's 40. But I have never seen any place what is the normal pulse pressure is. So I cannot comment what is the normal pulse pressure, but I can roughly say that if it is less than 20, it is significant. And if it is more than probably 60, then again it is significant. But I have never seen anywhere what is the normal pulse pressure is. Yeah, that's the answer for the first questions. And there are some more questions. The question is whether the vasopressors constrict only peripheral vessels or whole vessels in the body. Yeah, so generally, for example, noradrenaline, it will compress or constrict all the blood vessels in the body, including arteries, veins, and even the pulmonary circulation. And the next question, is it okay to increase the contractility in MI? In myocardial infarction, is it okay to increase the contractility? A very good question. We know it's not good to increase the contractility. It will worsen the oxygen supply demand balance. But anyways, keeping the blood pressure in the right place is important to keep your brain and your heart perfused well. So we have to have some sort of compromise. So we are knowing our limits. Yeah, another question, do we need to give a fluid bolus before inotrope in cardiogenic shock? Yeah, it should be very careful. You can try until your inotrope is ready, but you should be very careful in a patient who is dyspneic and who is having a lot of crepitation. You should not give. Yeah, those are the questions that I can see. Yeah. If somebody is having any other question, I'm happy to answer. Somebody has raised the hand. So Lahiru Yasas has raised the hand. Do vasopressors has an action of constricting peripheral vessels and dilating? No, it will constrict both vessels, the peripheral, central, venous, arterial, and even pulmonary blood vessels will be constricted.
Right. Dr. Lahiru can ask the question if you have a question. You can unmute and ask. Lahiru Yasas, you have a question? Okay. If there are no questions, I think we'll come to this current lecture. So thank you very much for your comprehensive lecture, sir.
Thank you. Thank you very much. Thank you very much for the attention. Thank you very much.
So we go to the next lecture by Dr. Tilini Nadisha on pre-op preparation. Over to you, Dr. Tilini.
Okay. Can you all hear me?
Yes, yes.
Okay. I'm going to share my screen. Can you see my screen now?
Not yet. Yes. Okay.
Okay. Good morning, everyone. So welcome to the last lecture. I think it's the last lecture from the College of Anaesthesiologists for this program. So my task is to discuss about the pre-operative preparation. As the name suggests, pre-operative preparation is that is what you are doing when you are going to how we are going to prepare patient for a surgery. So this is a bit of a different lecture compared to the other lectures that you had in the morning. So anyway, as house officers, you will be doing preoperative preparations, like if you are doing surgery or GynOps, it will be your routine day-to-day work, or even in the medicine or pediatrics, you may be having patients who are going for surgery from your unit itself. So therefore, it's important to know how we are going to prepare a patient for a surgery. So the objectives are, we will be discussing within the next half an hour. So what is pre-op preparation and why we need pre-operative preparation, and during the preparation, if there's any problem, how we are going to optimize the patient and why this optimization is needed, and overall, what is the house officer's role as a team member in the pre-operative preparation. So preoperative preparation, when you take the preoperative preparation, that is, so it includes the assessment as well as the optimization. So when a patient comes for a surgery, let's say elective surgery, initially you have to assess the patient, and like we don't send the patient straight away once the patient is admitted to the hospital, to the theater. So there are certain things of preparations that we have to do. So it will include the assessment and optimization. So we will discuss how you assess the patient for a surgery, and then how you optimize a patient for the surgery. So pre-op assessment. So why do you need this assessment? So why don't we send the patient directly to the theater? That's because so simply it is to see whether the patient, so to find the answer to the question whether my patient is fit for the surgery. So that's what we do, this pre-operative assessment. So by doing the preoperative, so the fitness for surgery, so how would you know the for a surgery? So basically, it will depend mainly on two factors. That is, what is the surgery the patient is going to undergo, and as well as the patient's current medical condition. So if the patient is for example, if we take the patient, we said surgery mean like it could be a minor surgery or major surgery. We'll discuss about the grade of surgery later. So it could be an elective or emergency surgery as well. So some of the patients who may be fit for electives minor surgery may not be fit for an emergency major surgery, depending on their conditions and the surgery. So that's why it is important. The other thing is their health status. So we have to assess those things when we are going to do the pre-op assessment. So pre-op assessment ultimately will ensure us to identify the problems of the patient, and so we can optimize them. And then again, we have to, if we identify that patient may have complications, so it's a complicated case, we can plan for the post-operative care. On the other hand, when you do a pre-op assessment, the patient will get familiarized with you and your staff at the hospital, and their concerns will be addressed. So as we all know, if you are going for a surgery, all will have a lot of concerns and anxiety. So those things can be relieved if we have pre-op assessment and optimization prior to surgery. So so who is going to do the pre-op assessment? So in your ward, so if there's a surgical list, there will be usually for elective surgeries, there will be an anesthetist coming to do the pre-op assessment. But it is not the case in all time, and it is anesthetists are not the only one involved. So in the pre-op preparation, it's a multidisciplinary, so that you know what's multidisciplinary, a lot of disciplines are involved. So it's not only the anesthetists, your ward doctors, that is seniors, and house officers mainly will involve in this assessment and optimization. And in addition to that, nursing staff and where indicated, other specialists like radiologists and cardiologists will also be involved in the assessment and optimization of these patients. So let's see how we are going to do the pre-op assessment. So the component of pre-op assessment would include that history, examination, investigation, as well as, you know, in any of the cases you do in the medical school, those parts are also involved. In addition to that, there at the end of this assessment, you have to stratify the risk. So we will discuss about that, how you stratify the risk for a surgery. So during the history, so you may be the first person, you are the first encounter as house officer when a patient admitted for a surgery or going for emergency surgery. You will be the one who will first see the patient and assess the patient. So first clerking will be from you. So in there, when it comes for a surgery, so general history taking and examination should go on. But in that case, there are certain things that you have to stress when you come to the pre-op assessment, assessing for a surgery. So history, what I mentioned is surgery. So why surgery is important? Let's say like if the patient has come for a thyroidectomy, so it could be, we have to know the patient has come for a, what is the indication? Like it may be a benign goiter or a malignant goiter. So in that case, like for example, let's say the theatre list is, there's a large theatre list and one patient, so you can't accommodate all the both thyroidectomy. So you may have to give the priority to the malignant. Likewise, it's just an example. So we have to know the indications and any other related issues, whether there is any complications related to this condition, whether there is a airway compromise, if it is a thyroidectomy, or whether there's any retrosternal extension, likewise. So it will depend. So in the history, you have to ask for them. And age, why I have mentioned it specifically is like age is important, because surgery, it is like change. It's not the normal physiology. We are going to alter the normal physiology. So age, a person, for example, if a person of 30-year-old come in for herniatomy and an 80-year-old come in for the same herniatomy, will have a totally different risk and totally different complications expected. Therefore, age is also important. And then during your history, you have to ask the patient about the past medical history and how the diseases are being controlled. So past medical history, what are the things that you are going to ask? So mainly you have to ask about, most of our patients will have diabetes, hypertension, and ischemic heart disease, as you all know. So we have to ask about the drugs, the duration and complications, whether they, for example, diabetes, whether they have had any hypoglycemic attacks, DKA, likewise. Those are important because they can go into them during surgery and post-operatively as well. And when it comes to ischemic heart disease, you have to ask whether the patients or whether the patient has go under any CABG, or whether the patient has got stents specifically. Like the patients may be on stents, so they may not mention it until you ask them. It's like if you don't catch, or if you don't find that, no one, sometimes everyone may miss after that you are seeing years of the anesthesia. So in that case, it could be can result in very devastating outcome. So therefore, it's very important. So in addition to that, we have to ask for the chronic lung diseases. Very important, because when it comes to anesthesia or general anesthesia, airway, and the respiratory system is quite important. So if they are having asthma or COPD or any other lung diseases, you have to assess them and see whether how they are controlled. Or other things like liver or kidney dysfunction, if they are having them, we have to assess how it is controlled. And neurological conditions may not be always there, but if there is a condition, then you have to ask about that as well. So if there are other medical disorders like blood disorders, so let's say like hemophilia, also those will also affect the surgery and anesthesia as well. Therefore, we have to ask for them during surgery history. And then the drug history is extremely important. So it's related to the medical history as well. So you should know what are the drugs the patient is on. Like it could be hypoglycemic, antihypertensives. So why it is important, the drugs? Because we may have to alter some of these drugs prior to surgery. When it comes to the surgery, we may have to change. We will discuss it later. So other important drug groups would be antiplatelet or anticoagulant, because some certain anesthetic procedures, spinal or epidural, may not be possible if the patient is on certain antiplatelet or anticoagulant. So the surgery may also not be possible. So therefore, you have to find out what are the drugs the patient is on. Then the allergic history is important. You may not pay a good attention when you are taking history in the medical school for a medical person, but allergic history is important not only for the antibiotics, but they may have allergies for various other things, maybe on a clonidine. They may be allergic to the betadine also, like so maybe they can develop anaphylaxis to some of the anesthetic drugs or the surgical things. So therefore, you have to have that also clearly documented, because if you don't find it at the clerking or when you are assessing, the patient may not mention that later also. So like we may miss that. So that is also important. And then past surgical and anesthetic complications is important because it's not only asking what is the surgery the patient has previously gone through, but we have to ask for the complications of that, like whether the patient has had any ICU admissions previously, why was the reason, and also specifically anesthetic complications, like the anesthetist who is coming for the pre-op assessment may do, but if it doesn't happen, or if they also miss, it may go unnoticed, but they may have had a severe airway complications or drug-related complications during the previous surgery. So that is therefore very important to ask about this complication during your breast clotting itself. And the other important thing, one of the thing is smoking history. Why it is important? The smoking, as you smoking has a lot of cardiovascular and respiratory or other organ involvement. So during anesthesia, they can get a lot of complications if they are currently smoking. So the cessation of smoking is advisable, and we always expect when it comes to an elective surgery. So therefore, you have to know whether the patient or the smoking history is also important to anticipate any complication also. And the other thing is the exercise tolerance. So what you mean by the exercise tolerance? So this is important when it comes to a surgery, specific, even general or under spinal anesthesia or whatever the surgery, whatever the surgery is, exercise tolerance is important to assess their fitness. So it will give us an idea about the cardiac as well as the respiratory fitness of that patient to undergo that surgery. So how would you assess the exercise tolerance? So there are various ways of assessment, but you have to know as house officers, you can be familiar with this, what is called the MET value. So this is MET value. MET, I think you may be familiar or heard about that. I don't know whether you are aware or not. So MET is metabolic equivalent of task. That means it gives the energy expenditure. The MET1 is equal to energy expenditure during a quiet sitting, when the patient is sitting quietly. So there's a value for that. So various activities that we do in life will have various MET values. I think you can see it on the screen. So various activities can have various MET values. So this MET value will give us an idea how fit or how the exercise tolerance of this patient. So usually for anesthesia or the surgery, we expect the patient to have a MET value of around 4, at least 4 or more than that. So if you look at that, so there are you can ask certain questions. So whether they can do their day-to-day activities, whether they can climb a staircase, or whether they are involved in whether they are by doing bicycling or jogging, or whether they are doing tennis, or likewise you can ask. So depending on that, you can have an idea about the MET value of this patient. So usually what we do is the climbing of a stair to get that 4, because as you can see, it gives a 4 value when it is a climbing stair. So we can ask about that. But if sometimes it may not be possible to find it out in a patient who is immobilized. For example, if there is a let's say like joint problems also, if they are not mobilized, you can't assess that. Then we have to go for other methods. So it's important all the MET value. So if someone asks about the MET value as house officers, so we have to say the MET is less than 4 or more than 4. So that is also important. So that is the exercise tolerance. So those are the things that we do in the history on the preoperative assessment. And then comes the examination. So during the examination, what you are going to do, so the examination, again, like for any other patients, you have to examine the patient, but you have to focus on finding certain things. Like in the general examination, most of the important things would some of the important things would be to see whether the patient is pale, because they may be anemic. So we can't go for a general anesthesia or spinal anesthesia for a major surgery if the patient is anemic. So they can compromise during the surgery. So we may have to give blood, optimize beforehand. So we have to see whether the patient is icterus. And in addition to that, specific things you have to look for if, as house officers, you may see various like obvious facial deformities, like it is related to anesthesia. Like if the patient is having obvious facial deformities, and let's say the patient is coming for an emergency surgery, and there won't be a time for an anesthetist to assess. previous. So then it's your duty to inform beforehand that there is some deformity. So because this will interfere with the ARV, I think you have done the anesthetic appointment of at least 2 weeks. So that will give you an idea, so they can assess and prepare for a difficult intubation or ARV. And other important thing in the general examination is the obesity. I have seen like most of the house officers may not concern about this obesity, like, but obesity, mind you, it's a disease. Like when it comes to anesthesia, it's a real problem, also surgery as well. It's a real concern, because if the patient is obese, they are more prone to have a lot of, DVTs and ARV complications, and post-operative complications are quite high if the patient is obese. Therefore, if you think a patient is obese, not at the weight, you have to assess check the BMI as well. For example, if you are going to work in the obstetric ward, and there is a patient for a cesarean section with a BMI and 40, and you suddenly send the patient for a section to the theater, is not the case. So that we can't go for a normal spinal for those patients, and you have to optimize, you have to start DVT prophylaxis likewise beforehand. Therefore, obesity is important. And then when it comes to cardiovascular system, so like for any other cardiovascular general examination you have to do, but I have to stress, like when during the first assessment, check your blood pressure pulse correctly. Like, because for example, let's say if there's a patient who is not who was not a diagnosed patient with hypertension, but when the anesthetist come for the pre-assessment, there is a very high, sky high blood pressure. So if you have not correctly, if you have also noted the high blood pressure initially, that may suggest that the patient is having high blood undiagnosed high blood pressure. But if your blood pressure you have not correctly measured, that we can't use it as assessment. Therefore, it's important. And then you have to carefully look for murmurs. So as house officers, you may be the first one to diagnose a pathological murmur of a patient. So if it goes unnoticed, the patient may go into a trouble during anesthesia. So you can look for those as well. And then you can look for pages of heart failure and other cardiovascular assessment to be done. The other important system that you have to examine is the respiratory system. So basically, you have to see if the patient is having any bronchospasm, or if the patient is having any features of respiratory tract infection. So because if the patient is having a respiratory tract infection, we don't go for elective surgery. So in the emergency surgeries also, we may have to do certain things before taking the patient to the theater. Otherwise, they are getting a lot of complications. So those are the main systems that you have to examine. But if there is any neurological problem, or if it is indicated, you can do the neurological examination as well. And then what are so after assessing an examination, what are you going to do? So as house officers, you will be the one who will order the investigations for these patients. So if we look at the investigation, so what are you going to order for a particular surgery? So the investigations that you are going to order for a patient will mainly depend on two factors. One thing is the grade of surgery. So how severe or how complex is the surgery, and also other comorbidities of the patient. So what I want to highlight for you all here is that you should not order or do not order all the investigation for each and every patient, because we have seen most of the house officers at the press conference, they may order all the possible investigations to the patients, which is not necessary, and it is a waste of time and patient's blood as well. So investigation should be tailored depending on the two factors that I mentioned. So we say, what is the grade of surgery? So grade of surgery, like surgeries can be divided as minor, intermediate, and major surgeries. So for example, minor surgery like excision of skin incision, draining of brain abscess, like, oh, those are the small or minor surgeries. So most of the time we may even not, if the patient doesn't have any other problem, we may not need investigations as well for that kind of a surgery. But then we come to the intermediate surgeries like inguinal hernia repair or SF ligations or tonsillectomy, like those surgeries, we may need certain investigation. But when it comes to major surgeries, Major surgeries are like TAH or lumbar discectomy, thyroidectomy, or various major lung surgeries. So those are major surgeries and complex surgeries. In those cases, we may require further or more investigation. So it depends on the investigation. So one thing is depends on the grade of the surgery. So one thing is the grade of the surgery, which will determine what investigations to be done. Other thing is the comorbidities. As I mentioned, the comorbidities. For example, if the patient is the diabetes patient, so we would obviously need a fasting blood sugar and the blood sugar control. If the patient is a renal patient, let's say a patient in the stage 2 or 3 renal failure, we will ask for the creatinine levels or the electrolytes and all. But if the patient, the well healthy patient of 20 years, we may not ask for the we do not need the renal functions or the liver functions. And also likewise, so it depends. So the thing is, you should not order all the investigations. So these are the possible investigations or the that we may have to ask. So you have to decide which patient need which investigation. So chest X-rays, like, so if the unless there is an indication to suggest any chest infection or any abnormality, or if the patient is going surgery involved in the lung also, we don't need. But we have seen house officers ordering chest X-ray for herniatomies as well. So that is not necessary. So that so therefore investigation should be tailor-made to the particular patient and the surgery, so that you have to have an idea. So what so actually at the moment there is no national Sri Lankan guideline to say to which investigation to which patient, but you can decide. So if you can't decide, you can ask the seniors whether to to do this or not. Otherwise, don't don't order all the investigation at the when you target a patient the first place, and don't go on asking for all the investigation. So it's a waste of time and money. And then now we are have assessed the patient history, examination, investigation. So I say the last part of that would be risk stratification. So how would you assess the risk? So how would you assess the risk? So risk assessment is like risk assessment is important, because now we said the patient has a certain risk during the surgery to have complications or to die also. So so therefore, risk assessment is important. So there are various ways or classifications of risk assessment, but this is a simplified American Society of Anaesthesiologists assessment for risk during surgery. We have this ASA classification. As house officers, you have to be thorough with ASA classification, I think. So that means if someone asks whether this patient is ASA 1 or 2, you should have an idea. So here we said ASA 1 is a healthy patient. That means the patient is not having any comorbidities. So that means the risk will be less. So ASA 2 is a mild systemic disease, mild to moderate systemic disease, but it's well under control. For example, if we take a patient who is having a diabetes well controlled or hypertensive well controlled, they come under ASA 2 category. Mind you, it's not mentioned here, but the patient was smoking, and also patients with overweight patients, the BMI, it's like, I think less than 40 comes under ASA 2. So that's what I say, obesity, even they don't have any other risk factors, they are not considered as healthy. So they comes under ASA 2 category. And then ASA3 is severe disease, that is uncontrolled disease, like say uncontrolled diabetes or uncontrolled heart rate or whatever. That uncontrolled disease, that it has limitation of it has limited the patient's activity. Whereas ASA4 is severe incapacitating disease, like means there's ongoing heart failure. The patient cannot get up with that or so on, or else patient had an MI, very recent MI. So those comes under ASA4. And then ASA5 is, it's a moribund patient. That means even we do the surgery or we do not the surgery, patient is unlikely to survive for another 24 hours. So that's you can understand that it's a very high risk for the patient to go under surgery in that kind of a situation, so they can die on the table. ASA6 is patients who are brain dead. So that is for the purpose of organ donation that is mentioned. So when you see a patient, you should be able to see whether this patient is ASA1 or ASA2 or ASA3. So for example, specifically if it's a casualty or an emergency case where there's no time for a pre-op assessment, if the anesthetist ordered from the theater, if you are being asked, you must be able to say whether the patient is ASA1 or 2 or 3, whatever. So this is how you assess the patient. So we say, so the preoperative preparation include preoperative assessment and then pre-op optimization. So now you have seen the patient and assess the patient and identify the problems, and then you have to optimize. So what are the things you are going to optimize? So first things to optimize is the medical condition. So you have to optimize the patient's medical condition. So like say, for example, if the patient is having diabetic or hypertension, so if they may be on drugs, so then you may have to alter or change the drug therapy to optimize the management. Or else if the patient may be newly diagnosed diabetes or hypertension or no ischemic heart disease, so then again, so you have to start drugs and do medical referral or optimize before surgery. So that likewise. Also, like for example, also specifically for chronic lung conditions or lung problems, this is important when it comes to anesthesia because they can get a lot of airway and related problems. So you may have to start bronchodilators if they have bronchospasm. You may have to start nebulization, or if there is a lower respiratory tract infection, usually we don't go we have to postpone the elective surgery. So then we have to optimize. And also chest physiotherapy and intensive spirometry. If it's a major surgery, irrespective of the conditions, we will start those things to increase and improve the lung compliance and those things. Or else, if the patient is having lung disease, we may start those things. And other thing is the stop smoking is extremely important. So that's why you want to ask whether the patient is smoking or not. So stop. Usually, actually, we have to stop the smoking ideally for 6 to 8 weeks. So even, but if you stop smoking at least for 24 hours, that has a better effect than the patient smoking just before going to the theater. So therefore, it's very important to stop smoking, counsel them, and to make sure that they are out of smoking when it comes to the surgery. One thing, so we have to optimize the medical conditions. And the other thing you have to modify is the drug therapy. The medical condition, as we mentioned, so diabetic and hypertension things we mentioned. So we may have to, for example, if we take diabetes, some of the oral hypoglycemic, we can't continue for the surgery. So we are going, patient is going for fasting. So if long acting some of the drugs, we may have to omit the night. If the patient is planned for a surgery in the morning, we may have to stop it in the night. Night dose as well. So insulin also is the same. We may have to withhold the morning dose. So that we have to know. So some of the antihypertensives, usually we continue the antihypertensives. You may have, sometimes you may have to alter them depending on the patient conditions. So other main group of drugs that you have to make sure to modify would be the antiplatelets and anticoagulants. So as house officers, you have to be very aware that the antiplatelets, like some of antiplatelet drugs, some of the drugs we can't continue because we can't go for spinal anesthesia or epidural with those drugs. So especially like a patient may be on clopidogrel. So we have to stop, we have to omit clopidogrel for 7 days before spinal or epidural anesthesia. For that, you have to know that the patient is on clopidogrel. That's why the drug history is important. So if they are coming for elective surgery, we have to stop that it for 7 days. For that, you have to make sure that you can't just stop the drug. I mean, like if, for example, if the patient is on a stent, they need dual antiplatelet, maybe on aspirin or clopidogrel. So you can't by yourself stop the drug. So in that case, we may have to go for cardiology opinion as well. So therefore, you have to make sure what are the antiplatelets the patient is on, and if needed, we may have to stop the clopidogrel or prasugrel. There are certain drugs we have to stop. And then the anticoagulants. So anticoagulants, I think they are like there are warfarin, enoxaparin, or heparin. The patient may be on. So if the patient is in warfarin, which is a long-acting one, we can't go for a surgery. So we have to change it to now if the patient is warfarin, we can't altogether stop it. So like there is a reason, like they may be having a cardiac valve or so certain thing like that. So we can't avoid we can totally withhold that for a longer period. So we have to convert it to something like enoxaparin or heparin. And then if the patient is on enoxaparin or therapeutic dose, we have to stop it 24 hours prior to surgery if they are coming for spinal or spinal or epidural, or for surgery also we stop that. And if the patient is on heparin, it's usually given as it is given as an infusion, so you have to stop it for 4 hours prior to surgery. And then, so those are the drugs things that we have to optimize. And then the other thing you have to optimize is the fasting. So fasting, I think you are all familiar with the fasting guideline. So fasting, you have to keep the patient fasting for solids for 6 hours and clear fluids for 2 hours. And when it comes to pediatric patients, if the patient is on breast milk, the fasting should be for 4 hours. So after 4 hours, you can give breast milk. But mind you that it's a breast milk. It's not the formula milk. So you have to make sure that it's only the breast milk. So what I want to stress related to fasting is you should always take measures to avoid over fasting. Fasting is needed, but over fasting is devastating. Like over fasting can cause, it is not present for the patient, and it can cause a lot of post-operative and intraoperative complications as well. Therefore, like we have seen, most of the patients are fasting for 12 to more than 12 hours when they come to the surgery. So that should be avoided. Like you can give clear fluids, water or king coconut water or dextrose water also up to 2 hours, unless it's a bowel surgery or we have prepared for more than 6 hours. So that make sure that patient is not over fasting. So fasting is like that. And then pre-medication. So pre-medication is some of the medications that we are giving prior to surgery, apart from the drugs that they are taking for their medical condition. So it again depends on the patient. So your anesthetist will decide or will order those drugs when they come for the assessment. So it could be antacid, antiemetics, or if the patient is anxious, they may prescribe anxiolytics, or they may be given preemptive analgesics as well. So those should be ordered. When they are ordered, make sure that they are taking them as ordered, like at the time that we may give it to prior to surgery and on the day of surgery for a few hours or 2 hours before the surgery or so on. So make sure that is given. So pre-medication is another part of optimization. So once you have optimized patient, what else you have to do? So you have optimized, assess and optimize and stratify the risk and inform the patient. So then other things that you have to do would be post-operative. Is one thing is the post of care plan. So when you assess or when you are assessing the patient, and if it is decided that there is a risk of complication, and if the patient need ICU care, so you have to book the ICU bed. So it's a house officer's duty to book the ICU bed, and most importantly, you have to make sure that the ICU bed is available just before the surgery, on the day of surgery, because booking ICU bed itself doesn't mean that you are the best bed is available. So you have to check it in the morning or where they are going. Otherwise, the patient may be undergoing surgery and there is no anywhere else to send the patient. And then informed written consent. I think there was a lecture on consent and communication previously, so I'm not going to talk about that. So you have to take it's a house officer's duty to take the consent for the surgery as well as for invasive procedures and general anesthesia or the spinal or whatever the mode. And then other thing is the grouping and DT. So you may have to preserve blood for certain patients and certain surgeries. So again, I have to make sure that, like investigation, all the patients do not need grouping or DT. So like if the patient is coming for a breast abscess drainage, they don't need either grouping or DT. But if the patient coming for, let's say, the joint replacement or lung surgery or something like that, they will need DT or the preserving of blood. So for a patient like I say, it's a patient with coming for a cesarean section with the placenta percreta, which there is postpartum hemorrhage risk, we may need not only blood, but blood products as well to be reserved. So this is basically house officers' responsibility. Once it's orders, you have to make sure that DT is available before sending the patient to the theater. And the other thing is send the theater list. Like send the theater list, you have to send it is written by you. So you have to, house officers should make sure that the theater list is sent early as possible. It's not to the particular place. Now, depending on the place you work, you may have to send it to the theater only, or maybe have to send to other particular places. So you have to make sure that the list is sent, because only the anesthetist will get to know what is the list is, and the theater will get to know and prepare with the equipments and all will depend on the theater list. So that is important. In addition to that, I forgot to say, like in this COVID era, so the investigations wise, you have to make sure that we need for general anesthesia or spinal, or we have to screen the patient for COVID-19. So usually we go with the rat value. So if you have to make sure there's a rat test done within 3 hours of the surgery. So otherwise that again be a problem. So PCR is not, if it is indicated, we will ask, but otherwise that should be within 3 days. So those are the things that you have to do before sending the patient to the theater. And finally, just before sending the patient to theater, there will be a checklist which is available in your unit. There will be a particular list in each and every ward. So that is usually ticked by the nurses. So make sure that all the drugs are given, fasting completed, and also on. So make sure that pre-op checklist is completed before sending to the theater. So that's all I have related to the lecture. Any questions I can take?
But there's a question saying, when can we start oral meals feeds after surgery?
Well, starting oral meals again depend on the surgery, but usually we don't delay. Like you said, like usually we say like it's we keep the fasting for 6 hours. Actually, it's not the case. Like it's a very minor procedure and so on. If there is no any the bowel or involvement of the gastrointestinal system, once the patient is awake and well, we can start oral feeds. For spinal also, we can start. I mean, irrespective of a GO spinal. But if there is a bowel surgery, or if we need to keep the patient fasting or to assess, then again we have to keep the fasting according to the surgical advice. Otherwise, we can start like it. We don't need to actually. Usually in the ward we wait for about 6 hours, but actually it's not necessary.
Okay, one question is drug modification for patients who are on anti-diabetic,
yeah,
and on anti-hypertensive or statins.
Anti-diabetes in the sense like some of there are drugs like diabetes drugs, so like they say about metformin and also those drugs we can continue. Even the morning dose we can give if we are sure that the patient can take the meal after the surgery. So but certain some of the drugs like glycoside or long-acting drugs we may have to stop, like it depends on the drug. Some night dose also we may have to stop. Insulin again, like when it comes to insulin, so most of the time we will have to stop the morning dose of insulin. But if the patient is on long acting insulin also, we may have to, like depending on the drug type, we may have to reduce 20% of the drug or so on. That will depend. So antihypertensives, usually we don't stop antihypertensives. Or if the patient's blood pressure is very low also, we may change. But most of the time, we can continue the antihypertensives. Statins wise, usually we don't need the statins. There is no, like, you can continue the statins. There's nothing special about the statins. But I think they have asked for aspirin. Aspirin we do not stop for anesthesia wise or spinal or epidural or even for the surgery. We don't recommend to stop aspirin. There's no need. But the drugs that I mentioned previously, clopidogrel and clopidogrel and other long-acting drugs, we have to omit for a particular period, like 5 to 7 days, sometimes to 10 days also there. So it depends. So Is that I can't see the question or anything else they have asked in that?
One more question. What are the normal values for FBS and BP value during major surgery?
It is a normal, like, it is a normal. There is no difference between it when it comes to the major surgery or normal. But thing is, like fasting blood sugars, like the normal levels for the fasting blood sugar. But when it comes to the major surgery, or if the patient is the diabetic patient, non-diabetic on drugs, at least fasting blood sugar for less than 140 is necessary to go ahead with the surgery. That is the level we usually want if the patient is non-diabetic. But if it is better than that, or if the normal value is there, that is the real target. But otherwise, less than 140 would be adequate.
The other question saying some surgeries recommend to stop statins preoperatively, like CABG.
Sorry, stopping statins. That of course not. We usually don't stop statins. That it depending on, of course, some depending on the brand. I don't know whether it's a in the cardiothoracic surgeons would need, but otherwise statins we usually don't stop even for the CABG. No. Anything else? They have asked briefly tell about post of paralytic ileus. I don't know what they have may want to know, like paralytic ileus. So it's like so if you have handled the bowels and like a lot of handling of the bowels are involved, or they can get paralytic ileus. So but it's like they will, like, it's a surgical question they have asked. So it's like if the patient is having floating abdominal distension and not passing platters and things, we may suspect the paralytic ileus. So in that case, but if the patient is very partial on many like early features, we can still continue with the feeds, but make sure that the electrolytes, like especially the potassiums, are corrected. And so that is the post-operatively that you have to mainly look for. So if the patient is having any vomiting or any aspirations, or if the patient is on NG tubes, or if there's abdominal distension, if they are not going passing platters and so on, we may suspect the patient is having paralytic ileus. So in that case, if they are full-blown ileus, we may be unable to feed them. Otherwise, you can always correct electrolytes and go so on to and see whether it's correcting. What else? So they have asked, how about blood pressure control in surgery? So again, it's the same, like blood pressure control, we need to have, so normal blood pressure is, it's 140 by 90. So a patient who is not non-hypertensive, we expect them to have this kind of a blood pressure. But if the patient is a hypertensive patient, like we at least, if it's an emergency surgery also, at least we need a systolic blood pressure of less than 180 or better 160, or diastolic. The most important, the diastolic blood pressure is the one is more important. So we expect it to be less than 100 to go ahead with the surgery. So especially for the hypertensive patients as well. And they have also asked when to stop breast milk and formula milk. I think we have discussed that. So the breast milk, it's 4 hours. For the formula milk, it's considered as a solid. So it is for 6 hours. Anything else? Then they have, when should be bridging be done? I think they are asking about anticoagulant. So bridging, it's again like as we mentioned that if the mainly bridging is needed, especially if the patient is in warfarin. Like if the patient is on warfarin, we have to convert into a low molecular weight heparin, that's enoxaparin, or we can convert it to heparin. So that is so you have to, it's like it take about 5 days for the warfarin action to be take over, and we want to need the INR to be normalized in that case. So that is, then they have to bridge like that. So if the patient is on enoxaparin, then we have to stop that. Like enoxaparin, if the patient is on the, I have mentioned this earlier, they are on the therapeutic dose, that means 1 milligram per kg dose, we have to stop it for 24 hours. But if they are in the prophylaxis dose, say for example for DVT, the prophylaxis or in the ICU, that 12 hours is enough. So heparin, they will be on infusion, so we have to stop it for 4 hours. So if they have stopped it for 4 hours, we can go for the surgery. So bridging is done depending on the drugs that they are on. So like we have to establish on the bridging therapy for about 2-3 days at least. So aspirin, again, they have asked, aspirin we don't need to stop usually for anything, for anesthetic point of view and the surgical point of view also, we don't stop aspirin now for before the surgery. They have asked what places we need to send the theater list. So you will know when you go to, like, it will depend on where you work. Like you may have to send it to the, I think the one copy to the office also, or to the theater. And sometimes, like if you are going to work in the NHSL also, there will be the exchange. You have to send it one copy to the exchange to be collected by the anesthetist. It's not from the theater. They collect it from the exchange. So likewise, you once you go there and start work, you will know where to send. So depend on that, you can send. Sodium citrate is citrate. Yeah, we are giving sodium citrate, that is only for patients who are undergoing section. That is on the table we are giving, that is to prevent aspiration, because these patients are at high risk of aspiration. So therefore we have to we have to give it on table, otherwise there can be a risk of aspiration. But it's not given in the ward, in the theater, or just before the surgery, before the operation, we give that. What else? So can HOs request for pre-op investigation themselves or after anesthesia referral and their assessment? So that's what I say. Like at the first clerking, you will be asking for investigation. So like for example, if the patient come in for a herniatomy of a 30-year-old, only the full blood count may be necessary. So it depends. So you can order that at that time. But if there is a particular investigation, like say 2D or 4 X-ray, if it is needed, that may be done after anesthetic assessment or after senior opinion, you can ask. So what I want to say, don't order all the investigation for all the patients unnecessarily, just because you don't know what to order. So you can order, I mean, at the beginning, but make sure that you don't order unnecessary investigations. Then could you be able, can I answer this? Is the time okay? So hello. So could you able to repeat what are the reasons why considering the obesity during pre-op assessment? What are the, so obesity, it's a disease, like it's a risk factor. Like obese patients, they can have airway problems. So they can have something called obstructive sleep apnea. So they can have snoring, and they can have related complications, cardiac complications. They can have pulmonary hypertension. So we may have not noticed or not diagnosed, and they are more prone to have this all the other hypertension and other causes as well. And also they can have, obese patients are more prone to have deep vein thrombosis. So after surgery, they are immobilized. They are more prone to get those conditions. So respiratory wise, there are complications, risk of pneumonia quite common and higher in obese patients. Therefore, in the pre-op assessment, so airway will be difficult. Therefore, we have to put extra care and extra precautions has to be taken when the patient is obese. Anything else? for the drug optimization, we'll all the time we need to do relevant MDT? No, not really, like not all the time. Sometimes you may be able to like change, like say if the patient is only on metformin 500 milligram and the blood pressure is not controlled, it is like to increase drugs can be done with your seniors as well. But if there is a major thing, or if the patient is first and newly diagnosed, we may have to go for a particular medical or cardiology referral depending on the patient. Can you please tell roughly around how many pints of blood we? It depends on the surgery, like so certain most of the things, most of the surgeries may not need any preservation of blood. Some we may have to go for grouping only, but for example, like a section or sometimes thyroidectomy, most of the time we don't do, but sometimes the herniatomy we don't need. But so sections like sometimes you put you have to put a one group of blood should be preserved. But as I said, like if the patient is having placenta previa or certain things, so we may have to have a 2 or 3 bloods. Or then if it's a patient, the Creta or a risk of PPH, we may have usually preserve 6 bloods. Likewise, it depends on the surgery. So it's a major surgery, we may have to preserve 2 or 3 blood pints. So just ask your surgeons how much of the blood pints that you have to reserve in kind of a major or complicated cases. I think I have answered all the questions.
I think that's all the questions. There some other more practical questions they might learn during their internship.
Yeah.
So I think that comes to a conclusion of today's program. Oh, yeah. Thank you very much, Doctor. Yesterday we had a session on doping and donning. It was not very clear, so I spoke with Dr. Harini, the college secretary, on critical care training. So we will be having additional lecture on that. Right. So those who have not registered on the link for pre-intern training, please do register. We will send you the link for Monday and time schedules. So look into your emails. We will send by Saturday or Sundays. So as informed by the College of Pediatricians, it will be a day session. So we'll have three-day sessions from Monday to Wednesday. So in future correspondence, we will send your emails. Also, we will inform your batch heads, batch monitors of further any special instructions. So that's all for today. So once again, thank you, Dr. Chilini, for your informative lecture. And those who have not got the vaccinations, please talk with your closest MOH. Right. So college, so there was a question, SLOG. So we have discussed with them, they have not responded yet. So we are trying to arrange a training with the yeah, anyway, those who have wanted to get this ALS courses, please register with the Research Sri Lanka at College of Anaesthesiologists. Okay, that's all for today. Thank you.